Good evening, everyone. If I'm visible and audible, please give me a thumbs up so that we can start with the session. Yes, am I visible and audible, guys? Sannyasi Pandit. Okay, I got a thumbs up from all of you. Chalo, let's start with this session. Any questions and doubts you can ask me. I can see Dr. Surya, Dr. Sannyasi Pandit, Dr. Smith Patel. ये सब नाम सुना हुआ लग रहा है यार. डॉक्टर स्मिथ पटेल भी सुना हुआ लग रहा है मुझे. डॉक्टर सूर्या भी सुना हुआ लग रहा है. Okay, so let me start with the session. Or shall we wait for some people to join in? Before we start, let's start one thing. Let's start on a good note. I know everyone is worried and tensed. So let's start the session straight away with a guitar part. Okay, if it's okay with all of you. So we'll wait for 2-3 people to join in. एक song करेंगे और उसके बाद फिर डिस्कशन शुरू करते हैं. Thumbs up all of you. Is that fine? Okay. Yes नहीं आया किसी का? Chalo, let's see. We'll do one song and then we'll start with the session straight away. By the time we'll wait for a minute or two so that everyone can join in the session. Okay. Small song. Okay, let's start with the session. Yes guys, ठीक है, तो शुरू करते हैं. Okay, so how have we planned this session right now? We are taking the previous year's test and discussion. More importantly, what we are looking at is the previous year's topics. Okay, and more than the questions, we are going to discuss the points related to the topics. We'll have the questions also, and along with the questions, we are going to discuss this out. Okay. ठीक है, so let's start. If you guys can give the answers, it will be well and good, and then we can have a discussion based on that, and then we'll go forward. This topic, emergency, from anesthesia or from, this is based on any other topic, whether it is surgery, orthopedics, any emergency patient coming, and how do you manage the patient, right? That's an important point. A patient of RTA and maxillofacial injury with Glasgow Coma Scale 6, BP 180 by 110, right? Heart rate of 50 per minute. What is the next step in the management of the patient? I would like to have your answers. Urgent CT head, NTG infusion, atropine, or intubation and ventilation. Anyone? Yes? Dr. Sannyasi Pandit, Dr. Smith Patel, Dr. Surya. The people that I can see. Yes guys? Yes, now I've got the answers also. Dr. Sannyasi Pandit says nice. Okay. Chalo, answer D hai. Absolutely correct. So as I said, more than the important question is the topic which is important over here. You have got a patient with RTA, right? The points given to you are Glasgow Coma Scale less than 6, BP 180, 110, heart rate 50 per minute. So a lot of people might think urgent CT head is needed because the patient is RTA. Yes, it might be needed. BP is 180, 110. Yes, you need to maybe decrease the blood pressure. Heart rate is 50 per minute. You have to give atropine, maybe, but the most important point here is the Glasgow Coma Scale. All of you know what is Glasgow Coma Scale? The basic point is just remember Glasgow Coma Scale. If it is less than 8, always try to intubate the patient, always. Because when the Glasgow Coma Scale is less than 8, the tongue falls at the posterior pharyngeal wall. So what you will see is that this patient is unable to maintain the airway. When people say airway can't be maintained, what's the meaning? The meaning is that the tongue has fallen to the posterior pharyngeal wall, oxygen can't go inside, carbon dioxide can't come outside. How do you take care of this patient? Do a laryngoscopy, intubate the patient, and this is the reason why you have to intubate the patients more often in emergency, because you want to maintain a patent airway. A patent airway means an airway which is open for gas exchange, and that's exactly what was needed over here, right? So the correct answer, all of you did say correctly, all of you said it correctly, was intubation and ventilation. That's the correct answer. Then here itself I'd like to discuss something about maxillofacial injury. So we discussed 2 points over here. One is regarding Glasgow Coma Scale. Remember, Glasgow Coma Scale less than 8 you intubate the patient, and Glasgow Coma Scale if it is more than 8 you keep the patient in the recovery position and basically you're supposed to observe the patient. That is the basic point as to how you will manage the situation. What happens when you get a patient with maxillofacial injury, right? You get a patient with maxillofacial injury, and all of you know the options given to you in a question like this will be: do you need to do oral endotracheal intubation? Do you need to put a nasal endotracheal tube? Do you need to put a tracheostomy tube? Or the last thing would be a surgical cricothyroidotomy. Surgical cricothyroidotomy is the same thing, which you see small, see in the movies, you must have seen, थोड़ा सा गला कट कर देते हैं और एक ट्यूब डाल देते हैं. That is surgical cricothyroidotomy. Now, basically, whenever you speak of a maxillofacial injury or any injury per se, remember, if you have to electively do something, it is different. And if a patient comes in emergency, it is different. Any kind of emergency situation where the patient is collapsing, you need emergency airway management. Remember, the correct answer to any emergency situation of the management of airway is oral endotracheal intubation. Okay? Emergency, because that's the first thing you will do, try to save the life of the patient. However, if you have planned, you have time, and you have elective airway management, you still have some time with you. So if the patient is a maxillofacial injury and you have to do a elective airway management, see, maxillofacial means maxilla, the face injury is there. You can't do anything on the face. So therefore, oral and endotracheal tube are out, and in that case, what you will go is for tracheostomy. That is an important point, right? And similarly, if it's an elective management in something like a cervical spine injury, in that case, perhaps you might go in for a nasal endotracheal tube, right? So this is our 2 important points that I need you to be, that pay attention to, which comes in the exam as well. That is the Glasgow Coma Scale, less than 8 intubate, Glasgow Coma Scale more than 8 keep in the recovery position, and maxillofacial injury, emergency, oral endotracheal tube, elective, go for tracheostomy. Thumbs up everyone, is that point clear? That's an important thing. Just waiting for a thumbs up, then we'll go forward. Correct. तुम्हारे messages आए नहीं यार, but ठीक है, let me go forward. Let me know, right? So we discussed about this. When we speak of intubation, guys, intubation. Let me cover that point here itself. When we talk of intubation, remember, whenever you intubate someone, remember this position is called as a sniffing position. It's also called as a McGill position. Some people call it barking position as well. What happens here is a head extension and neck flexion. Okay, head extension and the neck flexion. Head extension happens at the atlanto-occipital joint. Neck flexion happens at the lower cervical spine. Okay, so that is the position made for laryngoscopy and intubation of the patient, and then you're supposed to intubate the patient, right? Endotracheal tube going inside the trachea, right? That was the first thing when we were discussing. So we discussed laryngoscopy as well as intubation. Next question: a newborn child has respiratory distress. On examination, it is found that the newborn has cyanosis and scaphoid abdomen. Which of the following is not supposed to be done in the management of this newborn? Nasogastric tube, X-ray chest and abdomen, bag mask ventilation, or intubation? Yes, guys. I mean, these are the type of questions which are coming now from anesthesia, more than halothane, more than ketamine, more than thiopentone, more than propofol. Yes, I'm not saying they're not being asked, but they are concentrating more on the airway management, CPR questions, emergency management, and oxygen delivery devices is what we have seen as a trend. Yes, guys, correct answer to this question. I was waiting for answers from your end. Okay, nasogastric tube, X-ray chest abdomen, bag mask ventilation, or intubation. So the correct answer here is, what are you seeing in this patient, or what are you expecting? A child is having the respiratory distress, right? It's a newborn child that you're talking about. There's a respiratory distress. You are finding that there is a cyanosis and scaphoid abdomen. When you speak of scaphoid abdomen, newborn child, we are normally thinking about congenital diaphragmatic hernia. Okay, that's what we are looking at. So what will you not do in a patient of congenital diaphragmatic hernia who's just been born? So for a baby who's just been born, do you need to insert a nasogastric tube? Yes. Will you have to do an X-ray chest and abdomen? Yes. Intubation in a patient respiratory distress? Yes. What ideally should not be done is a bag mask ventilation. So what is not supposed to be done here, guys, is basically bag mask ventilation, because this will increase the chances of distress, and more distress can take place in the baby. Alright? Thumbs up, guys. मेरे को किसी को option नहीं आ रहा. I can see myself, but I can't see thumbs up and I can't see your responses. Somehow the other. एक बार refresh कर लेता हूँ. Let me refresh. Okay. Dr. Pranita saying, all sir, which PYQs from which year you're covering? I'm covering last 3 years. Actually, I wasn't getting your messages, guys. Okay. I'm trying to cover last 3 years. Okay. And not just from NEET PG, I've included questions from INI-CT also. That's the whole point. And also the ones on FMGE. Rather than PYQs, what we are targeting is PYT. Remember, it's not always the questions which are important, it is the topics which are important. So what we have covered right now, what you are seeing right now, is we discussed about intubation. Here we have discussed about bag mask ventilation, and the last 2-3 years, every paper, some question has come from intubation and something has come from bag mask ventilation, including FMGE papers. Alright? Including FMGE. All of a sudden, the messages disappeared. Okay? All of a sudden, the messages disappeared. Okay. Just a second, guys. Just a second. Just give me a second. Just give me a second, guys. Right, guys? Yeah, okay. Chalo. So we were discussing, as going forward from what we were talking about. Okay. So we were discussing bag mask ventilation, we were discussing congenital diaphragmatic hernia. So why is it that in congenital diaphragmatic hernia, you are not going to do a bag mask ventilation? We'll just discuss things in short. When we speak of bag mask ventilation, remember, bag mask ventilation is the same thing as what you called as AMBU bag ventilation. It's almost the same thing. Bag mask is what is done in the OT, and AMBU is what you are doing in emergency, in this casualty, in the CPR, at that point of time. So basically, what happens is when you are giving oxygen to a patient like this over here, so oxygen goes from here, it goes in the trachea, but some amount of oxygen is also going inside the esophagus. So what happens is it's going to distend the bowel, and in case the baby that we are talking about had a congenital diaphragmatic hernia, right? So those things have come into the thoracic cavity. So whatever oxygen you're giving, yes, it's going to the chest, no doubt about it, but some oxygen will also go inside the stomach, and from there it's going inside all the part of the herniation part which has gone inside the thorax, and this further will lead to dilatation of the loops of the bowel, which is going to increase the distress for the baby. So this is going to cause increased distress, and therefore bag mask ventilation is contraindicated ideally in a patient of congenital diaphragmatic hernia. This is called as risk of aspiration condition. So therefore, what are the conditions that are talked about as risk of aspiration? So risk of aspiration, this is not a absolute contraindication, but that was a relative contraindication. So conditions like pregnancy, ascites, right, tumors, obesity, they are considered as risk of aspiration, GERD, right? Diabetes mellitus, especially when there is autonomic neuropathy and there is delayed gastric emptying. All these conditions, wherever there is delayed gastric emptying, are called as risk of aspiration conditions. Apart from that, neonatal causes, when you speak of congenital diaphragmatic hernia, tracheoesophageal fistula, pyloric stenosis, and meconium aspiration syndrome, they are called as risk of aspiration. Patients with head injury, patients on opioids, they are considered as risk of aspiration, right? So all these conditions you have to be very careful with bag mask ventilation. In patients like pregnancy, congenital diaphragmatic hernia, ideally it's considered as contraindication and not to be given. So the correct answer to this question was bag mask ventilation. Rest other things can be done. Thumbs up. So we go to the next part, next question, right? Okay, very important. For which of the following the device shown in the image cannot be used? This was last year's question. Which of the following, for which of the following the device shown in the image cannot be used? Upper airway obstruction, acute, upper airway assessment, pulmonary lavage, and prolonged mechanical ventilation. What's the correct answer? A, B, C, and D. Dr. Surya says, Surya, yes. Dr. Kavi Yerasan says one answer. There are two options which I have gotten. There are two things, right? And that was the same confusion in the exam when this question was asked. It was almost the same thing, right? So here what you can see, the device is a tracheostomy. But what I'm going to discuss is true not just for tracheostomy, it's also going to be true for endotracheal tube. Okay? So here the two options that you people have given me are B and C, but the correct answer is B, guys, B. We are not going to use it for assessment of the airway. Na? We will not use it for assessment. The question is that following device cannot be used for what? The device that you see is tracheostomy. So go option one by one. Is a tracheostomy used for airway obstruction? Ideally, see, better is endotracheal tube, but if they're giving you obstruction, yes, you can be used. The same thing, the tongue has fallen back, you want a patent airway, you'll do it. Pulmonary lavage, it means suction. You need to do suction of the secretions which are getting collected in the lungs, right? Patient is unable to throw the secretion. For that, do you do a tracheostomy? Yes, you can do it. Same thing for prolonged mechanical ventilation. You must have seen patient in the ICU on whom we do a tracheostomy. So yes, it can be done. So the place where you are not going to be using this is upper airway assessment. Upper airway assessment means you're assessing the airway for either intubation or for bag mask ventilation or laryngeal mask airway insertion. Basically, you're doing it before the anesthesia or before putting an airway device. That is the time you're assessing the airway, right? So the correct answer here is upper airway assessment is where you're not going to use this device. So the point is, where exactly are we going to use this device? Indications. So what are the indications, guys? Indications of mechanical ventilation, indications of tracheostomy or indications of endotracheal tube intubation. So let me discuss with endotracheal tube, and all the endotracheal tube intubations normally hold true for tracheostomy also. Plus tracheostomy has other uses of ENT, which I'm not discussing, not the ENT part. But from the anesthesia point of view or emergency point of view, first thing is that you put an endotracheal tube whenever you want to maintain an airway which is open for gas exchange or trying to maintain a patent airway. Right? This was the whole point, which means you want to prevent an obstruction. That's the whole point. You don't want an obstruction taking place. And what is an obstruction? Obstruction is this part. The tongue falling back at the posterior pharyngeal wall is the obstruction. Right? So let's go forward. Patent airway. Second thing is whenever you want to protect the airway from aspiration. So when you want aspiration to be protected from aspiration, right? So whenever you want the airway protected from aspiration, right, you will put endotracheal tube. Whenever I have to give a mechanical ventilation for long duration of time, whether in the ICU, whether in the anesthesia department, whether giving long surgery, it's better to put endotracheal tube, not a tracheostomy, but all of them will hold true for tracheostomy as well. So when you do mechanical ventilation, you will prefer to put endotracheal tube and do that. This provides a point for pulmonary lavage as well. It's not gastric lavage. Pulmonary lavage means secretion, collecting the secretions or removing the secretions from the lungs. And the last thing is it can provide a route for emergency medicines that you can give, or from the endotracheal tube you can also give volatile anesthetic agents, you can give respiratory medicines, Budecort, salbutamol. So these are the indications of putting an endotracheal tube, and all of them will be valid for tracheostomy as well. Thumbs up, guys. Next question. Okay, when we're discussing endotracheal tube, guys, so here I will discuss one point regarding the parts of endotracheal tube. Recently lots of questions have been asked from endotracheal tube directly per se. So remember, this part that you see which gets attached to the umbu bag or to the anesthesia machine is called the connector. This is the proximal one, the last one which you see, which is inside the patient. So this is the machine end. We call it as the machine end of the endotracheal tube, which is towards the umbu bag or the breathing circuit where it gets attached to the connector. This part that you see is what is called as the bevel. And right above the bevel there is one point. Question, what is this? Anyone? This has been asked in the exam. Okay, this has been asked in the exam, so I'm asking you the same point. If you will see, it's not very clearly perhaps visible over here. There's a small opening that you see, and what is this opening called? Anyone? There are two more questions I'll discuss which have been asked recently, and this was one of them. What is this? Very nice, Murphy's eye, correct, very nice, absolutely correct. So you people are very well aware of the endotracheal tube. This is called Murphy's eye, and Murphy's eye is an additional port for oxygenation. Very nice. This is the cuff. Remember, nowadays the type of cuff that we are using is a high volume, low pressure cuff, which you inflate with air or saline. This is what prevents the aspiration. What you see over here is called as the vocal cord guide or the vocal cord marker, which tells you where exactly the endotracheal tube is placed, so that you're placed correctly. It lies at the vocal cords, right? The next point is this, which is called as internal diameter. It's written in all endotracheal tubes. Internal diameter, guys, is what tells you the size of the endotracheal tube, right? So that's the size of endotracheal tube. Also, another question which has been asked, resistance of endotracheal tube. So remember, internal diameter is what determines the resistance. Okay, the resistance of endotracheal tube, that is inversely proportional to the diameter. Means if the tube is larger, the resistance is going to be less, but if the tube becomes smaller, the resistance increases, right? So that is the point of resistance which has been asked. These are called markings, which are supposed to, which tells you where exactly they lie, you know, how far it is coming from the tip, the distance from the tip. So in a male patient, you keep around 21 to 23 in a male patient. A 19 to 21 is kept in a female patient. That is what is kept at the teeth. If you will see, there's a blue line that you see over here, this blue line. And that blue line that you see is called as a radio-opaque line that is seen on the X-ray. To know the exact position, radio-opaque line. And that radio-opaque line can be seen on the X-ray. Fine. So this is the pilot balloon. This is the inflation line. This is from where you put the air that inflates the cuff, right? So this is about the endotracheal tube, guys, and the markings and the various parts of the endotracheal tube. Recent questions have been Murphy's eye, right? Size of endotracheal tube. So remember, in a male patient, the most common size used is 8 or 8.5. In a female patient, the most common size is 7 and 7.5. So this has been asked, and Murphy's eye has been asked. The three important questions recently they've been asked. Okay. Next question. Continuing with intubation itself. Again, this was a recent question. As I said, we are discussing previous year's topics and questions. 30-year-old male patient was intubated, okay, in a surgery by a final year resident, right? Which of the following is the best method to confirm the position of the endotracheal tube? Right? Simple questions. Anesthesia has simple questions. My whole point of this session was to have a revision, a fast revision of all the topics that were important. And I'm taking the important topics very first, the recent questions very first, and then we'll go for those questions which have not been very important. So, end-tidal carbon dioxide concentration, absolutely correct. The answers that we have got here is correct. EtCO2, right? So, when you're confirming the position, guys, of course, when you put an endotracheal tube, what can you do? Auscultation, everyone says, correct. Auscultation can be done. I'm not denying. A lot of people say auscultation. Yes, it can be done. It's normally 5-point auscultation, absent at the stomach, equal at the two lung bases and the apex. But apart from that, the definite way or the best method to confirm is basically carbon dioxide coming out. So carbon dioxide is going to come out from the lungs only, na? It's not going to come out from the stomach. You will not get CO2 coming from the stomach. So CO2 is going to come out when it's from the lungs, right? So that is why, in this case, when the CO2 comes out, you keep a monitor in front of it. It detects the carbon dioxide, and that is what is called as capnograph. So capnography, okay, capnography or end-tidal carbon dioxide normally then becomes the best method to diagnose it. But there is something even better than this. What now people say is fiber optic. Because what fiber optic does is fiber optic gives you a direct visualization. So what happens in fiber optic is a direct visualization of vocal cords on the television. So you will find that in no exam both carbon dioxide and fiber optic have been given together, never. But in case both of them are given, I will still say that fiber optic would be a better option, because fiber optic tells you a direct visualization of the vocal cord that you see on the monitor. You actually see the vocal cords, right? In carbon dioxide, still it is slightly indirect. No doubt carbon dioxide is coming from the lungs, but still slightly indirect. But absolute correct thing would be fiber optic. You will see both these options have never ever been given in the exam together. Okay, so that's carbon dioxide, fiber optic. Apart from that, you have various indirect methods, which includes chest rise, which includes, absent, there is no gastric distension, no gurgling sound that you see, no cyanosis, pulse oximeter normal, all those signs which are there. In fact, that mist or moisture which you get on the sides of the endotracheal tube, that is also indirect signs. So these are indirect signs, and no doubt you can check it on the X-ray, or even ultrasound can be used to see that you have placed your endotracheal tube correctly and confirm the endotracheal tube, right? So that's about endotracheal tube, guys. Okay. Next question. Identify the marked area in the graph depicted below. This was also asked, I think, again last year. These are all recent, last 2-3 years, everything covered over there. Okay, so identify the red area marked. So this is the red area marked over here. What is this red mark? Is it residual volume? Is it functional residual capacity? Is it expiratory reserve volume or vital capacity? Yes. Anyone? So I'm just looking at the messages. Maybe there's a lag, na? So off and on. Right, absolutely correct. Question mark क्यों डाला Dr. Surya? Absolutely correct. That is functional residual capacity. Absolutely correct. Dr. Sannyasi Pandit also given the correct answer. Absolutely correct. FRC. So when you speak of the spirometry, guys, spirometry, this part which you see is what is called as the tidal volume. I mean, this is a physio part, but how it's important for anesthesia is what I will tell you. How it is important for anesthesia. When I intubate someone and I'm giving complete ventilation to a patient, don't you think spirometry will be important for me also? So just like physiology is the basic study that you do, in anesthesia, you're supposed to know the lung mechanics, lung ventilation, correct? The whole discussion was about endotracheal tube. So when you're giving a breath to the patient, so all this becomes important for anesthesia, and where specifically a question on this is asked, again I'll let you know. So therefore, this is tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume, whatever is left, that is residual volume. So this inspiratory reserve volume and expiratory reserve volume, guys, this is what is called as functional residual capacity, sort of oxygen bank in the body, right? This is where the oxygen gets stored. So people who exercise, their FRC increases. That's why they don't get breathless. People who are obese, who are not exercising, and where the FRC is low, is where they get breathless. So that's why FRC is so important in the exam. And for us, it is important because in anesthesia, when you do a pre-oxygenation of the patient, when you pre-oxygenate, what is pre-oxygenation? Pre-oxygenation means you are giving, I'm just looking at the questions as well. Pre-oxygenation means when you are giving oxygen to a patient for 3 to 5 minutes before intubation or before the surgery starts, all that time, what you do is you're given 100% oxygen. What does your 100% oxygen do? This 100% oxygen increases the FRC, it increases the PaO2, and because of this, what will happen is a normal person would desaturate. What is the meaning of desaturate? Desaturate means a normal person's SpO2 will decrease in 3 to 4 minutes. But if you pre-oxygenate someone, which is commonly done before putting the cricoid pressure, full stomach patients, right? Risk of aspiration conditions, where you pre-oxygenate the patient, what happens is because of pre-oxygenation, right? It's increasing the oxygen, and this pre-oxygenation prevents the desaturation, and a patient's SpO2, instead of falling in 3 to 4 minutes, it's going to decrease after 10 minutes. So you have bought time for yourself. You have bought time for yourself so that in that patient you can intubate. So that is why If it's a difficult airway, we always pre-oxygenate a patient. If it is a full stomach patient, we always pre-oxygenate a patient. In fact, most of the people from anesthesia, mostly whenever you are intubating any patient, you are never wrong. If you pre-oxygenate someone, you are never ever wrong. So by pre-oxygenation, you are giving 100% oxygen for 3 to 5 minutes, and this increases the FRC, this increases the PaO2, and because of this, a patient saturation will not fall for up to 8 to 10 minutes. Okay? Thumbs up everyone. So we go to the next point. So we discussed a lot about intubation. If you must have seen till now, we've discussed a lot about intubation. We discussed about bag mask ventilation. We discussed endotracheal tube, a little bit about tracheostomy. We also discussed about this point, which is your cricoid pressure, and we discussed full stomach patients. So all these become important topics, guys. All these are important topics from anesthesia point of view. Okay. Next. Again, a recent question. And as I said, it's not just about the NEET PG, because the NEET PG was held about a year and a half back. So that it's not just NEET PG. It's also about INI CET and the recent FMG questions. And as I said, it's not about the questions which have come in the exam. It's more about the topics. Okay, it's about the topics. Yes, guys, what's the answer to this question? Simple, but we'll just discuss them fast. Okay, which of the following scoring system is being depicted in the image? ASA scoring, Malampatti scoring, AHA scoring, or Cormack-Lihan? What is given is easy, but a question has been based on other questions as well. Okay, anyone? The answer? So I'm looking at the answers. At times, it straight away disappears. Correct. एक मेरे को thumbs up आया called भालू का दोस्त. Why that name is भालू का दोस्त? यार तुम्हारे तो नाम भी अजीब होते हैं, भालू का दोस्त. Correct, that is Malampatti scoring, right? So Malampatti scoring, it is not ASA, AHA or Cormack-Lihan. So when we speak of Malampatti scoring, guys, remember this is for difficult airway assessment, right? Malampatti scoring. Cormack-Lihan grade scoring जो होता है, that is your vocal cord grading. Whether the vocal cords are visible or not, it's done in ENT, or you can take it as a part of anesthesia also. Okay, you can take it as a part of anesthesia also. It's the vocal cord grading which you see, right? Then ASA scoring, right? ASA, American Society of Anesthesiologists scoring. This is basically a physical status. This is what tells you the physical status of the patient, right? When we speak of Malampatti, we'll just see that in short. Remember, Malampatti is basic. You're trying to see the posterior pharyngeal structures when someone opens the mouth. When you open the mouth, so there are 3-4 things you need to do. No, 3 things. First thing is open the mouth, extend the tongue. Right, you need to extend the tongue. That is important. The tongue needs to get extended, and nahi karna hai. No phonation. Do not phonate. Okay, do not phonate. You are not supposed to phonate here. So open the mouth, extend the tongue, do not phonate. And what am I supposed to do is to look at the posterior pharyngeal structures. If the structures are based on what structures is visible. So remember, if only the hard palate is visible, only the hard palate, you get class 4. If there is hard palate and soft palate, at the same time, you can see base of uvula. That is Malampatti 3. If hard palate, soft palate, right, all that is seen, and only the tip of uvula is not seen. Rest, you can start to see some or more structures over here. You can see those structures half structures, which are called tonsillar pillars. And the tip of the uvula is obscured. Tip of the uvula is obscured. It is not seen. That is Malampatti 2. And Malampatti 1 is when you see everything, which is uvula, which is the tonsillar pillars. So uvula, tonsillar pillars, the soft palate and the hard palate. Everything. A lot of people remember it as push also. Right? If you see all the push structure, which are the pillars, uvula, soft palate, hard palate. A lot of people remember like that. Okay. So that is called Malampatti 1. In the Malampatti 2, what will happen? This will become half. So the push is now out of that. The pillars and the uvula become half. Soft palate and hard palate are seen. In Malampatti 3, the P and U disappear. Only SH is seen, sort of. And the uvula base is seen. And Malampatti 4, even the S disappears. Only H is seen. Why is it important? This tells you about the whether the patient's intubation is going to be easy or not. Unanticipated patients, like who you don't expect difficult airway. In that kind of patient, how do you come to know? From Mallampatti classification. In a patient in whom uvula is seen, that would become relatively easy. So Mallampatti class 1 and 2 would be relatively easy intubation. Mallampatti class 3 and 4 are going to be difficult intubation. So remember, in the patients in whom you don't see uvula, in that patient intubation is going to be difficult. In a patient in whom you see uvula during the pre-anesthetic checkup, in that patient the intubation is going to be easy. And that is the reason why Mallampatti becomes such an important part of the pre-anesthetic checkup. In all the patients in a pre-anesthetic checkup, we always do airway examination, and one of the important things in airway examination is always to look at the Mallampatti classification. Okay, so that's about MPC grading. Next question. Since we were discussing ASA, let's come to ASA only. And this was last year's INI CET question. Last year's INI CET question, the same thing. Which of the following criteria corresponds to ASA grade 3? Mild illness, moderate illness, severe illness, or severe illness which is a constant threat to life? Yes. Correct. Correct. Absolutely correct. नहीं ये नेक्स्ट क्वेश्चन का आंसर दिया सर डॉक्टर सन्यासी पंडित से इज बी. और कोई आंसर? एक आंसर बी आया. डॉक्टर भालू का दोस्त, डॉक्टर सूर्या, डॉक्टर कवि. यस, अदर पीपल? अरे इतने सारे लोग देख रहे हैं, कुछ तो आंसर दो. सिवियर, it's not moderate. Yes, I know many places or many textbooks do say that ASA grade 3 corresponds to moderate to severe. I'm not denying that. Some textbooks have written it like this. I am not denying it. But ideally the correct thing is severe. You take it with an example. What does the ASA grading tell you guys? Basically ASA grading is telling you the medical status of the patient. It is telling you the physical status of the patient, right? Physical status is the medical status of the patient before the surgery. You are trying to classify the patient based on the medical illness that he has. So if a patient is normal, which means there is no medical illness, that becomes ASA grade 1. A patient who has mild will become ASA grade 2. ASA grade 2. So this is basically a mild but a controlled disease, like someone being hypertensive but the hypertension is controlled. That is ASA grade 2. And ASA grade 3 is not moderate, guys. Remember, if you can see here also, it is said severe systemic disease. So ASA 3 is not moderate. Remember, ASA 3 is severe. Okay, so ASA 3 is severe, and rather I'll rather put it this way. It is severe and uncontrolled. Uncontrolled, the same hypertension of a patient being uncontrolled is becoming severe disease, right? Uncontrolled. That same hypertensive patient goes into angina, it becomes a constant threat to life. It is so severe, that hypertension going into angina, that it has become a threat to life. This becomes ASA grade 4, where it is threat to life. So ASA 1 is no medical problem. ASA 2 is a controlled disease, sort of controlled, or physiological variations like pregnancy, pediatric patients. Mild disease is considered ASA grade 2. Uncontrolled, right? Uncontrolled or something severe is ASA grade 3. Like the hypertension being severe, and hypertension is going into its complications, right? It becomes so much complicated that there is a threat to life in the patient. That becomes ASA grade 4, right? And that patient gets admitted to ICU and lands up in obstructed hernia. So you will say what? The hypertension is 200 by 120 and the patient is obstructed hernia. What will you do? Whatever said and done, this emergency surgery has to be done, whether the BP is 200 or BP is whatever, right? So the point is that in a patient like that, or more commonly, I'll rather put it this way, in a patient who's got an intracranial bleed, it works more for patients like that, someone intracranial bleed, ICU patients, aneurysm, if there's a rupture. You can't wait for aneurysm rupture, let me control the blood pressure and then I will, take the patient for surgery. No, this ASA grade 5 is a patient who may or may not survive without the surgery. He is absolutely moribund patient, intracranial bleed, and if you don't do the surgery, he's going to go away. So better to get this patient surgery done. Forget about what is the medical problem. That's ASA grade 5. ASA 6 is a brain dead patient whose organs are being removed for organ transplantation. So that's the importance of ASA grading, guys. Remember, ASA grading is basically telling you the physical status of the patient, or the medical status of the patient before the surgery. In case you're doing an emergency surgery, you always attach the suffix E, right? That's ASA grading, important part at PAC. These 2 points of PAC have been asked recently, which is airway assessment as well as ASA grading. These 2 topics have been important previous year's topics. Thumbs up everyone. So I'll go forward. Right, next question फिर सीधा ले लेते हैं और यहाँ पे थोड़ा सा ड्रग्स डिस्कस कर लेंगे, ठीक है. सो आई टेक अबाउट 10-15 minutes. We'll discuss all the drugs in short because recently questions on drugs have not been asked. That's the question that I'm discussing right now. Which of the following agents has blood gas partition coefficient similar to nitrous oxide? This was January FMGE question. This is January FMGE question. Okay. So as I said, for me it's not about the question that I'm discussing, it's about the topic that I'm discussing. So I'm discussing with you the inhalational topic. But this is the question which was asked in FMGE January. हाँ जी बोलिए. Anyone? Answer? ये मेरा chat box ना slow चल रहा है. I can see myself but I can't see the messages. That is the problem. And I don't know why. I can see myself clearly. Yes guys, what's the correct answer here? Anyone? So, अरे मुझे किसी का आंसर नहीं आया. क्या आया? Dr. Anand Raj official. Very nice. Dr. Anand has given one answer A. Dr. Anand has given answer A. Anyone else guys? Dr. Anand, A is not the answer. इसको फिर हम लोग डिस्कस करेंगे. I'll discuss this. That's why I put this question. Though this was FMGE question, but guys it is a difficult one if you don't remember, right? A lot of people say FMG का पेपर easy होता है. ऐसा नहीं है. FMG का पेपर भी difficult होता है, right? When you know, you're supposed to know the topics and concepts. The correct answer here is desflurane. All right, the correct answer here is desflurane. So what are we talking about guys? So I'm discussing with you the topic inhalational agents. There are few topics, few points which become important in inhalationals, right? Inhalational agents like sevoflurane, desflurane, halothane. I'm discussing about that. So when we speak of their properties, there are 2 things which are important for inhalationals, right? And when we speak of properties of inhalational agents, inhalational drugs, there are 2 points which become important. One is the potency, which one is more potent, which one is less potent, which is strong, which is less strong, and second is which one will act fast. So potency tells you about the how strong or the strength of the drug, which one is strong and which is less strong. At the same time, you need to know the onset, which is fast acting, which is slow acting. So remember, there are 2 important points: potency and onset and recovery. The one which is fast onset will be fast recovery, the one which is slow onset will be slow recovery. So guys, remember, potency depends on a property which is called as minimum alveolar concentration, right? Minimum alveolar concentration. And onset and recovery depends on the property which is called as blood gas partition coefficient. Onset means blood gas partition coefficient, bhaga. Remember it as kaun bhaga, blood gas. Hindi, English में तो नहीं, you can't find out, but Hindi में you can remember like this. Blood gas means kaun bhaga. It tells you that in Hindi, right? So blood gas partition coefficient tells you about the onset and recovery. So now if you will look at the what you call the actual values, so minimum alveolar concentration you will find for nitrous 104, desflurane 6, sevoflurane 2, halothane 0.7. In fact, there's methoxyflurane also, another agent. इसमें जगह नहीं है. Let me write it here. Methoxyflurane. इसका value होता है 0.16 and here the value is around 15, 12 to 15, right? Blood gas partition coefficient. So as I said, minimum alveolar concentration is what tells you potency, right? It tells you potency. So the one whose value is more, that is less potent. You will find nitrous oxide not less potent. In fact, you find this to be the least potent, right? On the other hand, methoxyflurane is supposed to be the most potent, right? And this all will fall in between, with most potent to least potent, right? That is the potency. When we speak of blood gas coefficient, remember the numbers are not easy to remember, and we'll not remember for the exam, but there's a way to remember them, right? Blood gas partition coefficient tells you onset of action, onset of effect, and the recovery. So nitrous oxide if you will see, the value is less, and so this becomes very fast onset and fast recovery. On the other hand, methoxyfluorine, halothane, you will find slow onset and slow recovery. Can you see it's all going like this, inversely proportional? So point is, potency or MAC, what does it tell you? Minimum alveolar concentration. This becomes inversely proportional to potency. It is inversely proportional. Similarly, onset and recovery is inversely proportional to blood gas partition coefficient. Inversely, both are inversely proportional. How to remember this in the exam, guys? So for exam, the numbers, as I said, is not easy. So when you speak of minimum alveolar concentration, remember at one end is methoxyfluorine, and this is supposed to be the most potent. M for methoxyfluorine, M for most potent. At the last end of the spectrum, you get N, nitrous oxide, which is not potent, and not potent means it is the least potent, right? Least potent. In between, you can just remember it as his dream, right? Halothane, isoflurane, sevoflurane, desflurane, nitrous oxide. This is the point. Now, when you speak, or this is what is telling you potency. So this is the sequential arrangement from most potent to least potent. When you speak of blood gas partition coefficient, which can also be called as blood gas solubility, which can also be called as blood gas solubility, right? Blood gas partition coefficient or blood gas solubility. Here I can use the same thing. I can use the same thing over here, like methoxyfluorine at one end, halothane over here, isoflurane, sevoflurane. Till here it's the same. Slight difference I can do is I can put nitrous oxide here, desflurane here, and a new agent xenon over here. And so this becomes the same thing. The only difference I've made in this part, okay, and change the directions, and this becomes your answer to methoxyfluorine being the slowest onset and slowest recovery. On the other hand, xenon becomes the fastest onset and fastest recovery. And in the exam question which was asked, desflurane has its value closer to which one? Forget about the values. So if desflurane is asked, it is closer to which one? Desflurane is closer to nitrous oxide and desflurane is closer to xenon. So let's see what options was given in the exam for FMG students. The options given were halothane, isoflurane, desflurane, sevoflurane. So they have asked you which of the following has blood gas partition coefficient similar to nitrous oxide. So answer here is desflurane. If you look at adequate values over there, can you see desflurane value is 0.45, nitrous oxide value is 0.47. They are almost similar to each other. That is the answer. But you can't remember them so well always, numbers. So just try to remember it through this. So what was asked is this was 0.47 and this was 0.45. If you look at sevoflurane value, the next one which is there, it is 0.65, right? As I said, it's not easy to remember the numbers. Here the answer becomes 0.65, right? So sevoflurane is 0.65. 0.65. So you find nitrous oxide to be closer to desflurane, and forget about the numbers. I said numbers are not easy to remember, so remember this part. Thumbs up everyone. Is it clear? This was about inhalationals. This sequential arrangement was asked in the 2021 INI-CET exam, where they asked you to arrange the inhalational. So again, that's a recent topic. And in FMGE, they have asked you about this blood gas solubility. Yes guys, thumbs up, all of you. Did you understand? बीच में मेरे पास messages नहीं आ रहे हैं, तो तुमको ना फटफट message भेजना पड़ेगा, then I'll come to know, okay? Because I can see a lot of people seeing it. Let's go forward to the next part then. As I said, we are discussing some important points of each of these questions as well. So when we are speaking of inhalationals, guys, when I talk of inhalationals, so let's talk about halothane, let's talk about the important ones, isoflurane, we are talking about desflurane, and we are talking about sevoflurane. Right, where they are used and what are the problems. Remember, for halothane, the biggest problem is that it can cause hepatitis, right? It is known to cause arrhythmias. These are two important things with halothane. So you can't use it for liver and you can't use it for heart patients. On the other hand, the point is it's a sweet smelling agent, right? And it's a bronchodilator. It's a sweet smelling, it's a bronchodilator. So the only place you can use it is maybe in pediatric patients for pediatric induction, and you can use it for asthmatic patients who are asthmatic, right? Isoflurane. You will find isoflurane properties. This is the one which maintains cardiac output because it maintains baroreceptor reflex, right? So on the other hand, you will find it causes the least increase in intracranial pressure. So ideally, isoflurane is the best drug for a cardiac patient and one of the best drug for a CNS patient. Least increase in intracranial pressure, right? Best drug for that. Desflurane is one which causes sympathetic stimulation, slight increase in heart rate and slight increase in the blood pressure. Okay, it causes sympathetic stimulation. Desflurane normally is preferred to be used in patients with renal disorders. It is used in daycare surgery, right? It's not a daycare surgery, it's because it's the fastest acting here. Can you see this? Daycare surgery, it's the fast onset, fast recovery. That's what you want in daycare. So it's used for daycare surgery, renal patients, and it is also used in patients of shock because it causes sympathetic stimulation, right? Normally. Sevoflurane, on the other hand, has no production of trifluoroacetic acid. It is non-hepatotoxic in nature, absolutely non-hepatotoxic. It is sweet smelling. It is bronchodilator. So you will find sevoflurane to be used everywhere. In fact, nowadays people say, of course, it is the best drug to be used in liver patients ideally. So it's non-hepatotoxic. In a cardiac patient also, people prefer to use sevoflurane because isoflurane theoretically says that it can cause coronary steal phenomena. So especially in patients with myocardial ischemia and all those patients, you prefer to use sevoflurane, right? It's also used in patients in CNS, right? CNS, it can be used. So sevoflurane as well as isoflurane can be used there. Renal patient, there is one problem with sevoflurane. Of course, you can use it in pediatric patients and you can use it in asthmatic patients, right? It's done for this, so you will see it's used everywhere. The only place where sevoflurane has a problem is that if you use it with soda lime, it forms compound A, and compound A is nephrotoxic. Because of that, in renal patients, we prefer to use desflurane. Otherwise, most of the places nowadays, people are using sevoflurane. Okay, so compound A is produced. Thumbs up, everyone. Is it clear? That's about the inhalationals. In short, drug of choice, you came to know where it is used and what are the important properties of all four of them. Okay, halothane, isoflurane, desflurane, sevoflurane. Yes guys, thumbs up. Thumbs up रहता तो मेरे को समझ में आता है कि भाई तुमको समझ में आया. ओके, तुम्हारे मैसेजेस एक्चुअली आ रहे हैं पर पीछे आ रहे हैं, मेरे को सामने बीच में नहीं मिल रहे हैं, बट ठीक है, थम्स अप मुझे तो दिख गया. राइट, नेक्स्ट नाउ एज आई सेड, इन आगे भी जो क्वेश्चंस हैं ना अपने पास, इट्स नॉट मोर अबाउट ड्रग्स, सो आई एम गोइंग टू डिस्कस IV ड्रग्स ऑल्सो. यस, थम्स अप. आई विल डिस्कस द IV ड्रग्स ऑल्सो. आई गॉट अ थम्स अप. सो लेट मी डिस्कस द IV ड्रग्स ऑल्सो इन शॉर्ट, बिकॉज IV पे रिसेंटली क्वेश्चन पूछा नहीं है, बट आई जस्ट डिस्कस इन द सेम मैनर द IV क्वेश्चंस ऑल्सो. राइट, IV. सो IV ड्रग्स में गाइज रिमेंबर, अरे अरे ब्लैक हो गया, वेट. IV ड्रग्स में यू हैव थायोपेंटोन, you have propofol, you have etomidate and ketamine, right? Propofol, ketamine, etomidate. So guys, remember thiopentone is the same group as a barbiturate. Barbiturate is phenobarbital, and phenobarbital is used for CNS. So thiopentone is the best drug for CNS and ophthalm. Most of the times, okay? It decreases the intracranial pressure, it decreases the cerebral blood flow, decreases cerebral metabolic rate, and it is anticonvulsant. Right? So therefore, the place where you will use or you can use thiopentone often is CNS and ophthalm. Problem with thiopentone is that it causes histamine release. Histamine release, it can lead to bronchospasm, it may be a bronchial irritant. Achha, one more point. Desflurane is an important bronchial irritant also. This was 2020 question. This video I forgot to mention here. Bronchial irritant. This was asked in 2020 or 2021. Which of the following is the most bronchial irritant out of the following? Right. So that was about desflurane. Okay. So what we are discussing now is about coming since I was discussing this point, bronchospasm. So thiopentone causes bronchospasm. Histamine release and bronchospasm can be there. All right. Then we'll talk about propofol. So only place where we use thiopentone is CNS and ophthal. CNS and ophthal is where you can use. Apart from that, you are not going to use thiopentone anywhere. It causes. अच्छा, one more point. CNS में एक और चीज़ आ जाता है, which we don't think, right? Away from CNS, and that is treatment of raised intracranial pressure and also narco analysis. Again, all related to brain only. All related to brain only. This is where we use thiopentone. It causes bronchospasm. Propofol, on the other hand, is something that decreases everything. So same thing what you see over here is there in here also. Decreasing intracranial pressure, decreases cerebral blood flow, alright, decreases cerebral metabolic rate, slight anticonvulsant. Not upon that, it decreases the blood pressure, decreases the heart rate, decreases the cardiac output. It causes the maximum respiratory depression. It decreases the airway reflex. Everything gets decreased with propofol. And that is the reason, because airway reflex is also getting decreased, right? In this patient, this drug becomes the best drug to be used for intubation LMA insertion. And that is why in most of the places, everywhere we are using propofol. I'll come to that in a while. But these are the important properties of propofol regarding various pharmacodynamics. Ketamine, on the other hand, look at propofol and increase everything, it becomes ketamine. Yeah, I'm coming to take your surgery. Right, I'm coming to that. I'm just telling you where things can be used. So you look at propofol and look at ketamine, make it ulta. It increases cerebral blood flow, increases cerebral metabolic rate, right? It increases blood pressure, cardiac output, heart rate. Also, oxygen demand is getting increased with ketamine. Respiration increase matlab it maintains respiration. It causes the least respiratory depression. It increases, it maintains the airway reflex also. It maintains respiration. It maintains the airway reflex. In fact, ketamine becomes a bronchodilator. It increases everything. Bronchodilator. Right? This is the best drug to be used for a respiratory patient who's got active bronchospasm. K for ketamine, K for kids. Best drug to be used for that. One of the best drugs that can be used for short procedures because it maintains respiration. Right? So, thiopentone was one of the best drugs to be used in CNS ophthal. Ketamine becomes the best drug to be used in respiratory patients, kids, short procedures. Problem with ketamine is its E. And what is the E of ketamine? Emergence delirium, hallucinations. It produces emergence delirium or hallucinations. So K for kids, E for emergency delirium. It produces emergence delirium or hallucinations, right? Because of which you have to give benzodiazepine to the patient. It also increases secretions. Etomidate, on the other hand, just remember one way. Etomidate is the most cardiovascular stable drug out of all the IV that we have. So it is the best drug for CVS. So you have your answers clear. Mostly for our respiratory patient, it is ketamine. For CVS patients, cardiac patients, insufficiencies, it is etomidate. And for CNS and ophthal, normally thiopentone is preferred. But because propofol is a very, very fast acting fast acting IV agent, it has a very fast onset and a very fast recovery. It also moves away from the liver as well as from the lungs, the metabolism. It produces a very, very pleasant recovery, very, very fast and pleasant recovery. And therefore, forget about ketamine being used in respiratory patient and etomidate being in cardiac patients. Most of the places, everywhere nowadays, the drug of choice, apart from what we've mentioned, is propofol. It also has anti-emetic property, anti-pruritic property, antioxidant property. Everywhere we use propofol, everywhere, apart from what we have mentioned, right? So you will say, if etomidate is the most cardio stable and we use only CVS, why don't I try to use etomidate everywhere else just like propofol? Because etomidate has the problem of complications, and that is adrenal suppression. It causes adrenal suppression, because of which it is a problem. Right? Apart from that, lots of nausea, vomiting, and myoclonus which can be there. Myoclonus like focal seizures and all. So it is not used for CNS. It is not used for respiratory patients. This is used only for CVS, etomidate. Right? So this was in short thio, propofol, ketamine, etomidate. And by everywhere else, in propofol, if you ask me what are the indications where propofol is used nowadays, everywhere: liver patient, renal patient, old patient, daycare surgery. It's a drug of choice for induction. It's a drug of choice for maintenance of anesthesia. it's a drug of choice for TIVA, it's a drug of choice for sedation, it's a drug of choice for ICU sedation, it's a drug of choice for malignant hyperthermia, it's a drug of choice for porphyria, it's a drug of choice for LMA insertion, it's a drug of choice for endotracheal tube insertion, it has got anti-emetic property, it has got anti-pruritic property. So you look at that, what we have mentioned apart from, in fact, it can also be used for respiratory patient with no active bronchospasm. So you will find that ketamine, though being the drug of choice, propofol is one drug which is still used in respiratory patients. This is the most common used IV induction agent. Thumbs up, guys. Based on this, you can see, it's just a small discussion which I had, right? So hopefully people have understood. Any questions and doubts, ask me. So complete inhalationals and IV, we've tried to finish off as fast as we could. Yes? कोई किसी को doubt है तो बोलो. Just looking at the messages, so as to what you guys have said. Anyone? ठीक है, you guys have understood? ठीक है, तो आगे चलते हैं, next question देखते हैं. So we've discussed about complete inhalationals, we discussed IV. As I said, the questions from inhalationals and IV have been less in recent times. Okay? So going forward. Next question. A patient is undergoing surgery, is maintained on anesthesia with halothane. During the procedure, the patient suddenly develops hyperthermia and muscle rigidity. Which of the following drugs is most likely implicated in the condition? 𝐷𝐄𝐄 curare, suxamethonium, cisatracurium, rocuronium. Anyone? What's the answer to this question? 𝐷𝐄𝐄 curare. ये ना कट गया टाइपिंग में. Anyone? What's the answer? Dr. Anand Raj has given one answer. कोई और? Anyone would like to differ from Dr. Anand? नहीं. ये important question है. The topic भी important है. What am I discussing? What topic is this? This is correct answer to this question is suxamethonium. नहीं, डॉक्टर सिस भी नहीं है, डॉक्टर सन्यासी पंडित. सिस एट्राक्यूरियम भी नहीं है. सबसे पहले सोचो हम डिस्कस क्या कर रहे हैं. द पेशेंट डेवलप्स हाइपरथर्मिया एंड मसल रिजिडिटी. आई एम डिस्कसिंग द कंसेप्ट ऑफ मैलिग्नेंट हाइपरथर्मिया. अभी मैंने लिखा था प्रोपोफॉल में, देखो कहाँ गया प्रोपोफॉल हमारा. Here we have written drug of choice for malignant hyperthermia, propofol. Inhalationals are not supposed to be used. Succinylcholine is not supposed to be used out of muscle relaxants. That is malignant hyperthermia. Okay, that is malignant hyperthermia. So we are discussing malignant hyperthermia over here, right? And this looks confusing because they have given the option as only muscle relaxants. So you are not thinking in terms of malignant. Had this answer, यहाँ पे अगर ये छोड़ दो, a patient is undergoing surgery, and if I leave this point, that's how they ask in the exam. If I leave this point, I cut the question here, and I give the answer here like this: halothane, second is isoflurane, third answer is desflurane, and fourth answer is sevoflurane. All of you will give the correct answer halothane. Correct. Correct. ठीक है? All of you will give that the correct answer. ठीक है? So going forward. Right, let's discuss what is malignant hyperthermia. So malignant hyperthermia, guys, malignant hyperthermia is a genetic disorder. Malignant hyperthermia is a genetic disorder of the sarcoplasmic reticulum. Okay, patient having a Raynaudin receptor gene abnormality, and remember RYR gene is nothing but a calcium release channel in the sarcoplasmic reticulum. It's a calcium release channel. So now a patient is already having genetic disorder. He has it, but he has no symptoms. This patient has no symptoms. The symptoms happen when you take him inside the OT, and inside the OT I expose him to anesthesia drugs. Pharmacogenetic disease, if you want to call it, it's a pharmacogenetic disease. I expose the patient to anesthesia drugs. Which ones? Volatile anesthetic agents like halothane. If I use succinylcholine, in fact even lignocaine, local anesthetic, all of them can cause malignant hyperthermia. Suddenly what happens, something goes wrong with the calcium release channel और भर भर के calcium निकलना शुरू हो जाता है. It causes increased calcium release. So now the point is, if you are getting increased calcium release, now imagine where is sarcoplasmic reticulum. If you think from top to bottom, every muscle is going to have it. From all the muscles एक साथ calcium release होना शुरू होता है, which suddenly increases the metabolism. And because all the muscles get involved suddenly, it causes muscle rigidity. All your symptoms are because of all this. Okay? The increased calcium release changes the potassium also. It can cause arrhythmias in the patient. The increased metabolism increases the carbon dioxide production and increases the temperature. The muscle rigidity involves the muscles and can cause myoglobinuria. So now you have a patient who lands up with arrhythmias, a fever which is not going down, and a continuous rise of capnography. EtCO2 increases and the urine becomes slightly blackish in color, myoglobinuria. This is what is called as malignant hyperthermia, where the temperature increases and does not decrease. The patient can be dead on OT table. There can be a death on the OT table. The only way to treat it is stop this calcium release which is taking place. The whole concept was this. It started from here. So you need to stop the calcium release. The only drug which stops the calcium release is, next MCQ question. You know the answer. Which is the drug that stops this calcium release? So what is the treatment of malignant hyperthermia? Treatment of malignant hyperthermia in the OT. What is the treatment? What stops calcium release? This is asked in the exam. Next question. ऐसे अपने को question आता है. ये question आता है means what, you know, लोगों को ये आता है अपने को question आता है. Suddenly question आ गया. That's how the question comes. So that is dantrolene sodium. Right? So dantrolene sodium is what stops the calcium release that is taking place. Okay? It's dantrolene sodium. Right? So it stops the calcium release, and of course you need to cool down the patient, gastric lavage, IV fluids, right? You can use the rectal route as well. So dantrolene sodium is what stops the calcium release, and of course you need to cool down the patient. You have to use IV fluids which are cold. You will do a gastric lavage. You can use the rectal route. Okay? So all that's supposed to be done. And in case this patient comes for surgery, this patient with genetic disorder comes for surgery, the next time if you want to give general anesthesia, your drug of choice becomes propofol, which we have mentioned. And if you give local anesthesia, your drug of choice becomes procaine, because you can't use lignocaine. Thumbs up, guys. Okay? That is malignant hyperthermia, an important question. All of you? Yes? So going forward to the next one then. Okay? If there are no doubts, I'll go forward. डॉक्टर भालू का दोस्त, आप तो अपना नाम लिखोगे तो अच्छा लगेगा ना बोलने में. मैं बार बार बोल रहा हूँ, गुड डॉक्टर भालू का दोस्त, गुड डॉक्टर भालू का दोस्त, विनीश का दोस्त, ऐसे लिख लो. Okay, next question. The image given below shows neuromuscular monitoring of the patient after anesthesia. Simple question. Which of the following is the most common used nerve for this monitoring? Yes, guys. Answer. Simple. What nerve can you see? Is it median nerve, the ulnar nerve, radial nerve, metacarpal nerve? Correct. Absolutely correct. Simple question, important question. It has been asked. As I said, we are discussing all these topics which have been asked recently, and neuromuscular monitor was one of the important questions which have been asked. Okay, it's the ulnar nerve. So what we're doing is we're discussing the neuromuscular monitor. What does the neuromuscular monitor do? The neuromuscular monitor, basically it monitors the neuromuscular junction. So if you're saying the neuromuscular monitor, it is monitoring the neuromuscular junction. Basically it's monitoring the neuromuscular function. It's monitoring if the muscles are paralyzed or not paralyzed. That's what it is doing. Okay. That's what it is seeing. Muscles are paralyzed or not paralyzed. All of a sudden, when everything disappears, the messages, then I have to open it again. Okay? Because I have to see कि मेरा आ रहा है कि नहीं. Messages. Yes. Now I can see. Correct. Neuromuscular junction or the paralysis. That is what is being monitored. Why? Why are we monitoring the neuromuscular junction? Because when we speak of these skeletal muscle relaxants, guys, the skeletal muscle relaxants or the neuromuscular blockers, the neuromuscular blocking agents, they work at the neuromuscular junction. These drugs work at the nicotinic receptors. They work at the nicotinic acetylcholine receptors. Based on how they work on the receptors, they are classified into two types. Okay, so when you speak of these drugs, like when we are discussing these muscle relaxants, when I discuss the drug muscle relaxant, or I'm discussing the neuromuscular blocking agents, guys, depending on whether they can cause depolarization or no depolarization, based on that I can classify them into two types: non-depolarizing and depolarizing. As the name suggests, remember, all of you already know physiology, so I don't have to go into too much details of that. You're aware of things, right? So whenever there is depolarization, it means there is going to be a contraction. If there is non-depolarization, means there is no contraction. So in depolarizing, you will find one of the hallmarks is fasciculation. Non-depolarizing has no fasciculation. Simple, just on without even knowing the drug. Without even knowing the drug, you know the answer. Okay? Without even knowing the drug, you know the answer to this question. Okay? We have not looked at the drug, just knowing the classification. Okay? Based on that. So therefore, I'm just discussing a part of muscle relaxant before I go to the neuromuscular monitor. So non-depolarizing has no contraction, no fasciculations. Depolarizing on the other has contractions and fasciculations. Non-depolarizing means there is no contraction, which means it is going to be something which prevents the acetylcholine from going inside. So this is basically competitive inhibitor. On the other hand, depolarizing is causing depolarization. So this causes something which is called as persistent depolarization. Two names which are important. So this being an inhibitor, because it does not prevent a contraction, is because of which it causes paralysis of the muscle, flaccid paralysis. Correct? On the other hand, here what happens is there is persistent depolarization, so it becomes refractory to further depolarization. Right? This is what is called as the phase 1 block. Phase 1 block of what? So now let's look at the drugs. Non-depolarizing are all the drugs that we know. You can classify them into two types. The non-depolarizing, I can classify them into two types. Non-depolarizing, if I have to classify, so based on structure, I can classify them as aminosteroids and benzyl isoquinolinum compounds. Aminosteroids are going to be pancuronium, there is going to be 𝐌𝐞𝐝, there is rocuronium, and there is rapacuronium. On the other hand, benzyl isoquinolinum compounds are D-tubocurare, you will find doxacurium, you have atracurium, you have cis-atracurium, and you have mevacurium. So can you see curium and onium? There's a difference between them. You can find that. Correct? Now, in this same classification, I can have another classification in the same one. So this pancuronium, DTC and doxacurium, they will become long-acting muscle relaxant. Long-acting. 𝐌𝐞𝐝 and rocuronium here, and atracurium and cis-atracurium on the other hand, benzyl, this will become intermediate acting drugs. And you will find rapacuronium and mevacurium to be short acting. This is another classification. So long acting, intermediate acting and short acting, these are the classification of muscle relaxants. Okay? Aminosteroids, benzyl isoquinolinum are the chemical structure, that is the classification based on that, and based on duration, long acting, intermediate and short acting. So you have all of them, right? And depolarizing, there's only one drug which is used. There's no other drug available nowadays. Clinically used is only one drug, which is succinylcholine, which can also be called as suxamethonium. In the past, there was another drug called decamethonium, which is not used now. Correct? So this is your depolarizing and non-depolarizing. Now how can you differentiate between them? Neuromuscular monitor. So neuromuscular monitor is something which can help you differentiate between the types of block, and it can tell you whether it is blocked or not blocked. Simple. Whether the muscles are blocked or not blocked. The whole concept was regarding contraction. The whole concept was regarding depolarization, and that's exactly what you're going to see from the neuromuscular monitor. So in the neuromuscular monitor, what you do is you're going to give some stimuli. So the ulnar nerve, you give 4 stimuli, and the stimuli will travel from the action potential over here. If there is paralysis, there's going to be no movement. If there is no paralysis, there's going to be movement. If there is partial paralysis, there's going to be some movement. That is exactly what it tells you. The neuromuscular monitor basically tells you whether the muscles are paralyzed, not paralyzed, or half paralyzed. And that is exactly what is neuromuscular monitor. So how does it help you then? For example, surgery is going on and the surgery is going to take about 2 hours. Based on the duration of action that we were seeing, vecuronium effect is only 20 minutes. So for how long will you give it? Use the neuromuscular monitor. Every 20 minutes, instead of giving, you can check if the muscles are moving or not moving. If the muscles are moving, then only you repeat. If it is half moving, you repeat. If they are not moving, do not repeat. That's how the neuromuscular monitor helps you. So when we discuss the neuromuscular monitor, it is monitoring the neuromuscular junction, it monitors the paralysis, and basically it's working. You can differentiate between the types of muscle relaxants, right? And it tells you whether the muscles are paralyzed or not paralyzed. Based on that, you can repeat or not repeat the muscle relaxant, right? Now, when you talk of neuromuscular monitor, it monitors one nerve and one muscle. So the most common used is the ulnar nerve. This, remember, is the most common used. This was the question asked, and the corresponding muscle is adductor pollicis muscle. But a lot of people say the ideal is facial nerve. Facial nerve, orbicularis oculi muscle. Okay? So that's about neuromuscular monitor. The mode which we commonly use is a train of 4. You give 4 stimuli which are each of 2 Hz in a span of 2 seconds, right? If there is no block, you get 1, 2, 3, 4, same height, same response, right? And if there's a non-depolarizing block which is partial that you will get something called as fade, right? You get something like this, 1, 2, 3, 4. This is seen with non-depolarizing, which is called fade. With succinylcholine, the one that we saw, phase 1, you get same height, less amplitude and same height, no fade. However, when we speak of succinylcholine, guys, remember succinylcholine, normally when we speak of non-depolarizing drugs, another point, non-depolarizing, remember, can be reversed with neostigmine, and for non-depolarizing and for neostigmine. Depolarizing does not need neostigmine. There is no neostigmine. So what takes care of succinylcholine, or what degrades succinylcholine, is plasma cholinesterase. And if someone has plasma cholinesterase deficiency, it goes into sort of phase 2 block, right? So succinylcholine has phase 1 and phase 2 block, and phase 2 block shows you the same thing as fade. That's it. Okay? That's a neuromuscular monitor in short. Any questions or doubts? Otherwise I'll go forward. Yes, guys, any questions or doubts? We discussed neuromuscular monitor also. कोई डाउट है किसी को? नहीं? So let's go forward. Okay. A 15-year-old boy reported to the emergency department with breathing difficulty. Monitor was attached and the following graph was seen. What can be the diagnosis? Yes, what can be the diagnosis, guys? Malignant hyperthermia, pericarditis, cardiac tamponade, acute bronchial asthma. So what do you think, all of you? Yes, anyone? What is the answer? कोई नहीं? Simple question है ये तो. This is a simple one. So the correct answer is acute bronchial asthma. This is what is showing you capnography. On the capnography, you get a graph which is showing you a shark fin appearance. This is what is seen in obstruction, right? So whenever you put an endotracheal tube, we had discussed before, the best sign to confirm endotracheal intubation was the carbon dioxide coming out from here. This is what was called as capnography, correct? You would take it. So whenever carbon dioxide comes out, you get a graph, right? Inspiration, it goes down. So there are these three phases which you get, dead space, mixed alveolar and dead space, and dead and alveolar, and after that you get inspiration. This is what happens, right? So this part is the expiration, this part is the inspiration. Expiration and inspiration. So this is how it goes. Till here is the expiration. From here to here is the expiration. This is inspiration. This one. So graph going down is that. Now this is what is seen in IPPV. A patient breathing normally is going to get a graph like this, sort of up and down, spontaneous breathing. You get a graph like this. And if you get a graph which is not very clear but coming regularly, which means expiration is not coming out well. Ideally expiration should have been like this, but that's getting blocked. So the expiratory part is not very clear. It is getting obstructed. It's not in the ideal situation. It should have come like this, but it is not coming like that. This is what is telling you about obstruction, or this is what is bronchial asthma, which you just saw. Okay, everyone? Clear? So next question. Right, एक और question होगा. कहाँ गया? Yes, one more question is here. Then we'll go back to the previous one. So 60-year-old male patient was undergoing lap cholecystectomy. This was again last year's question. During the surgery, it was observed that there is sudden decrease in EtCO2 to 8. SpO2 was 90%. BP dropped to 80/50. Peak airway pressure was observed to be 18. Which of the following is the most probable diagnosis? CO2 embolism, pneumothorax, endobronchial intubation, or bronchospasm? Yes, anyone? अब ये सब difficult question है. When it comes in the exam, it's not very easy to give this answer. Here, when I'm discussing anesthesia, it would become simple. But if it comes in the exam, guys, it's not a very easy answer. Anyone? I can't see your messages here. 6 बजे शुरू हुआ था, 1.5 घंटे हो गए हमारे. Imagine how much we have covered. A lot of topics until now. We have, according to me. If there's something else that you want me to cover, let me know. मुझे messages नहीं आ रहे हैं. And I don't know, मैं refresh करता रहता हूँ फिर भी नहीं आ रहा है. Yes. So what is the answer here? Here the correct answer is A. Carbon dioxide embolism. CO2 embolism is what we are looking at. Okay? The correct answer is A. Carbon dioxide embolism is what we are looking at. ठीक है? Carbon dioxide embolism. Now the point is, what is it that is happening during the procedure because of which this has taken place? First thing is laparoscopic cholecystectomy. So here surgery is going on laparoscopically, and nowadays what is being used presently, the gas for laparoscopy, is carbon dioxide, which means the surgeon is insufflating carbon dioxide inside. During the surgery, it was observed that suddenly EtCO2 has fallen down to 8, means a normal value of carbon dioxide. In the patient now, this was a carbon dioxide gas used for laparoscopy. A patient's normal EtCO2 value is approximately the same as the PCO2 value, and all of you know PCO2 is 35 to 45. So EtCO2 value normally is between 30 to 35 or 35 to 40 if you can take, so 30 to 40 is what is EtCO2 value. It's almost the same as PCO2, right? So now the normal value of EtCO2 instead of 30 has come down to 8. So a lot of you will just have bronchospasm. Bronchospasm will not make it fall immediately, and more importantly, in that case you will say look at other options. Along with decrease in EtCO2, you are observing that the saturation has also fallen down. So bronchospasm, yes, it can happen. Saturation can fall down. The BP has also fallen down. Can it happen? Yes, that can also happen. But the point which differentiates from other is the peak airway pressure was observed to be 18, and the peak airway pressure 18 is not considered high. This is almost considered normal. If there is a spasm happening, if there is an increase in the airway pressure, if there is some resistance to the flow, all of that is going to increase the peak airway pressure. Here the peak airway pressure is not increased. There is a fall in EtCO2, there's a fall in saturation, and here the answer becomes embolism. So when we speak of a carbon dioxide graph that we were talking about, EtCO2, so we had discussed what type of graph is normal in EtCO2, right? We discussed here. So now if the EtCO2 graph further becomes like this, it was like this, it was going on like this, it was going on like this, and suddenly it becomes like this, which means something has gone wrong here. What has gone wrong? First thing is that it can be disconnected from the circuit. Second, there can be an accidental extubation, means think of the normal causes first. Suddenly there is no carbon dioxide coming out. This means there is no carbon dioxide or very less carbon dioxide coming out. So there can be what? There can be suddenly no metabolism in the patient, which is cardiac arrest. Right? So disconnection from the circuit, accidental extubation. In fact, almost a flat line this type CO2 is seen in esophageal intubation, because if the tube is in esophagus, you are not going to get carbon dioxide. But a similar thing falling down is what is seen in embolism. So remember, this is what is asked over here. When you say an embolus, so that embolus will go and block the heart. There are the chambers of the heart, right? Chambers of the heart. So the embolus goes and it blocks the heart. Embolus is blocking the heart. So nothing goes forward, nothing comes here. And because of that, there is no metabolism taking place, right? So embolism has blocked the heart, because of which now you are going to get a decrease in EtCO2 and going to get a decrease in the SpO2. And all this is because now no metabolism, sort of metabolisms get, there's no exchange of gas that is taking place. It's going to decrease the blood pressure of the patient, but the peak pressure of the patient remains sort of normal. That is not increased, right? So this is why the correct answer here becomes embolism. Clear everyone? That was based on EtCO2. ठीक है, सब ग्राफ हो गया अपना. Next question. Any doubts? Anyone doubts, guys? No one is asking me a doubt now. कोई डाउट नहीं है किसी को? So ठीक है. Next question. Young male patient was given regional block with 0.25% bupivacaine for a minor surgical procedure. Shortly after the injection, patient suddenly became unresponsive. Pulse was not recordable. Which of the following would be the best course of management for this patient? Yes, anyone? Is it CPR with 20% interlipid, CPR with sodium bicarbonate, CPR with dobutamine, or CPR with calcium? This was a previous year question. In fact, all of them are, but this was a direct question. Yes, anyone? Yes, anyone? Answer? I'm looking at the answers, trying to look for that. Nahin? So let's go forward. The correct answer is CPR with 20% interlipid. A is the correct answer here. Okay? A is the correct answer. I can't find the messages now यार. I can't see. In fact, कोई message कर रहा है तो मुझे दिख नहीं रहा है. Till now I could see all of them. All of a sudden in between it just disappears. So just wait for a second. I will just open the me a second, guys. Okay. Chalo. So let's go forward now. Here I'm discussing a question, right? Here I'm discussing a question where a male patient is given a regional block with 0.25% bupivacaine, right? It was a minor surgical procedure. Suddenly, shortly after the injection, the patient became unresponsive, pulse is not recordable. So what will be the best management? What are we discussing about? You have given bupivacaine, and bupivacaine has caused the local anesthesia. Oh, I got one person, Dr. Prathamesh. Thank you. I had a guitar session here also right now, right? We'll have a guitar again. Okay, we'll have a guitar again right now. Okay, so now going forward. तो एक message अभी मेरे को दिख गया. Thank you so much, Dr. Prathamesh. Right? Going forward. So we have a young male patient given regional block with 0.25% bupivacaine for a minor surgical procedure. So what am I discussing? Bupivacaine, after giving, suddenly the patient is not responding, pulse is not recordable. It's the most cardiotoxic local anesthetic. Remember this. It's the most cardiotoxic. So what have you caused is a local anesthesia systemic toxicity. And nowadays, remember, no doubt you have to take care of the symptomatic part. You know, there's going to be arrhythmia. So when you speak of local anesthesia systemic toxicity, remember, the CNS symptoms always take place before the serious symptoms. Local anesthesia. Okay. When you speak of local anesthesia, these drugs are working at the nerve, right? Muscle relaxants were at the neuromuscular junction. Local anesthesia works at the nerve. It works more at the sodium channels, and not just sodium channels from the top. They basically supposed to go inside. So they work in the sodium channels intracellularly. They have to go inside and work intracellularly, inside the cell, right? So they work on the sodium channels intracellularly. That's how they work, right? Local. What are they doing? Sodium channels basically were going and propagating the action potential. So the local anesthesia stops that action potential or the impulse from going forward, right? And how does it form? How does it stop it? By working at the sodium channels intracellularly, right? Now, because it's working on the nerve, it's easy for the local anesthetic drug to cross the CNS. That is why when you speak of local anesthesia systemic toxicity, the CNS symptoms tend to take place before the serious symptoms. Normally, the CNS symptoms before the serious. So you tend to see a patient, first with convulsions, you know, with oral, and before you get to see the arrhythmias and the cardiovascular collapse. The problem is when you speak of bupivacaine, remember bupivacaine is the most cardiotoxic. Bupivacaine is the most cardiotoxic, where you get the serious symptoms almost at the same time of CNS symptoms, and you get an immediate collapse, right? And the treatment for that then would be to take care of the symptomatic treatment. And what is the symptomatic treatment? Take care of the convulsion, take care of the arrhythmias. Apart from that, nowadays 20% intralipid. Intralipid is the same thing which has been used for total parenteral nutrition, right? This is what is called intralipid. This is used for bupivacaine toxicity. It works as a binding agent or a chelating agent, and it takes it away, right? That's how it works. So therefore 20% intralipid is what is used. Infusion, you use this intralipid infusion, and also small doses of adrenaline can be used. Small doses of ADR, you can use small doses of adrenaline. So this was the answer which has been asked recently, and not once, it has been asked twice, I think. Not just about NEET PG, it has been asked in FMG also, similar question. So this is what covers our local anesthesia. We've seen the site of action also. Remember, because this local anesthesia drugs are working intracellularly, hence the important points here are going to be lipid solubility, plasma protein binding, right? The pH of the drug, the pKa of the drug, right? All these things will become important. Also, all these drugs are normally vasodilators. All the local anesthesia drugs are vasodilators. That's exactly why you use adrenaline, because adrenaline will cause vasoconstriction, and therefore you get a better effect. That's why you get local anesthesia drugs combined with vasoconstrictors, because all of them inherently have vasodilator property. So which are vasoconstrictors then? So remember, most of the local anesthesia drugs are vasodilators, and that is why you have local anesthesia plus adrenaline, ADR plus, this is 1:2 lakh commonly used, right, the concentration. And vasoconstrictors that you get are cocaine, ropivacaine and levobupivacaine. Rest all of them are vasodilators. So these drugs are not supposed to be used with adrenaline. They all cause slight hypertension. Okay. So this is about the local anesthesia drugs, their important properties that we saw. When we discuss ADR, what are the concentrations of ADR which are used? So remember, adrenaline, when it is used for anaphylaxis, the concentration used is 1:1000, right? This is supposed to be given IM. When you are using it for CPR, you use 1:10,000. This is given IV. When we use it with local anesthesia, this is 1:2 lakh. So this is what is used for, epidural or infiltration or with local anesthesia for that effect. So this is your doses of adrenaline. This was again a question asked as match the column in INI-CET. The route of administration and the various doses, ADR. Going forward, guys, so this also we have done. Right, next question. Now, important one. Every exam this question has been asked. Structures. Patient presented with headache, vomiting, fever, meningitis was suspected while performing lumbar puncture, which is the last structure you will pierce just before entering the lumbar cistern. Yes, anyone? Let me know the answer. What do you think so? Then we'll go forward, right? Remember, as in for the discussion. Yes, anyone? Dr. Anand Raj says the answer. Okay. Correct. Absolutely correct. It's the arachnoid membrane. Absolutely correct. Okay. Absolutely correct. It's the arachnoid membrane that is going to be getting punctured before the lumbar cistern which is there. So when you speak of, spinal, epidural, whichever you're giving. So remember, normally the spinal cord is something which starts from medulla oblongata and finishes at the lower border of L1 or the upper border of L2. So this is L4, L3, L2, L1. You find, spinal cord coming and getting over here at the lower border of L1 or the upper border of L2. This is where it gets over. So when you give spinal anesthesia, all of you know, you always give it over below L1, L2. The most common space given is L3, L4. When you give spinal, this is the most common space that you use, right? Because, and how do you identify that? By using the Tuffier's line, the line joining the highest point of the iliac crest or the anterior superior iliac spine that corresponds to the L4, L5 interspace or the L4 spinous process. This is where you give spinal. Epidural can be given anywhere, cervical, thoracic, lumbar, sacral. Why? Because because of the way where you're inserting them. When you speak of the structures that you pierce, so the first structure that you get anywhere is going to be the skin. Of course, after that what you get is the subcutaneous tissue. So let me use the red one. Okay. The first thing that you get is the skin, then comes the subcutaneous tissue, then covering all the spinous process. This is called as the supraspinous ligament. Then you get a ligament which is, in between all of the two spinous process. It is called as interspinous ligament. So if you will look at the structures which are getting pierced when you're going from the back to the patient, the first is the skin and the next is subcutaneous tissue. Remember, this is what we were talking about, the spinal cord. It gets over at the lower border of L1 or the upper border of L2, right? Skin was the first structure which we saw. Skin, followed by that was the subcutaneous tissue. Then we saw the next thing, supraspinous ligament. Then a ligament in between, which is called as the interspinous ligament. Then you get a ligament after that, this one, which is called as ligamentum flavum. So this ligament which you will see, this one. Okay, let me put it from here. This is called as ligamentum flavum. After ligamentum flavum, okay, after ligamentum flavum, the next structure that you get, okay, Okay, the next structure that you get is what is it called as the epidural space. Okay, so that is what is called as the epidural space. So epidural space is what you see over here, epidural. Okay, so that is what is called as the epidural space. So ligamentum flavum, once you have gone through the ligamentum flavum, this space that you see, this is what is called as the epidural space. Can you see this is the epidural space? Until now you have not encountered the dura. Once you go beyond the epidural space, the next thing which you get over here, this is the dura and the arachnoid. Okay, so after the epidural space, the next that you get is the dura. Of course, after that is going to be the subdural, and then there is the arachnoid. Inside the arachnoid, this is the CSF. This is where you give the spinal anesthesia. This is the lumbar system. So after the arachnoid, you get the subarachnoid space. This is what contains the CSF. The lumbar cistern is this one, right? This is where you give the spinal anesthesia, right? So in the spinal anesthesia, because you're puncturing the dura, you don't want to puncture the dura at a place where you puncture the spinal cord also. Hence, spinal anesthesia is always given below the level of L1 and L2 so that you don't damage the spinal cord. However, when you speak of epidural space, it's a space lying outside the dura. You're not coming in contact with the spinal cord, and that is why when you speak of epidural can be given cervical, thoracic, lumbar and sacral, and the sacral epidural is what is called as caudal anesthesia. Caudal anesthesia. So therefore, when you give spinal, the last layer or lumbar cistern, lumbar puncture, the last layer punctured before the spinal anesthesia is arachnoid. When you speak of epidural, the last layer punctured before epidural is ligamentum flavum, right? When you give caudal anesthesia, this ligamentum flavum goes down, it becomes sacrococcygeal membrane at the sacral hiatus. So when you talk about caudal anesthesia, you are puncturing the sacrococcygeal membrane, right? So these are the various layers which you are going to get pierced in various types of anesthesia. Thumbs up guys, is that okay? All of you, did you understand? We discussed epidural, spinal, caudal, all of them, and the layers which are pierced before that. Yes or no? ठीक है सब लोग? Any questions, doubts till here? Let me go forward then. ठीक है? Next question. Okay, so no doubts till then. Let me go forward. A child is being delivered oxygen by nasal cannula at 3 liters per minute. ये last year का INI-CET question है. This is last year's INI-CET question. A child was being delivered oxygen by the nasal cannula at 3 liters per minute. What is the FiO2 being delivered? 25%, 30%, 35 or 40? Yes. What do you think is the answer? Yes, what is the answer according to you? 25, 30, 35, 40. So, in a question like this, I would stick around with 30. Why is that? We are discussing nasal cannula. A nasal cannula is the same thing as nasal prongs. So, when you speak of nasal prongs, guys, so this is the nasal cannula. So, when you use nasal cannula, remember there's a formula. Normally, you can use nasal cannula between 1 to 6 liters, but the maximum FiO2 that you get is around 44%. How do you derive? It's from a formula. Normally it is considered 20 plus 4 into the flow into liters per minute. Okay, you will multiply it like this. So therefore, if you start at 1 liter per minute, right? If you started taking this formula into hand, I told you it works at 1, 2, 3, 4, 5 and 6 liters. This is the various flow liters that we are seeing. So each of them multiply by 4, and you need to add 20. So this is 4, 8, 12, 16, 20, 24, right? And add 20 to each of them. This would become the FiO2 being delivered. 24, 28, 32, 36, okay, 40, and you see 44% at 6 liters. Can you see this? 6 liters is 44%, 1 liter here is 24%. The question asked in the exam was, you have started the patient at how many liters? 3 liters per minute. And how much should be the ideal FiO2 being delivered? So here what is being delivered accordingly, there are 2 points. At 3 liters you are getting 32. So therefore the correct answer here is 32. Correct answer here is 32. But 32 is not given. So what is the correct answer? Is it 30 or 35? A lot of people will say, sir, 35 is the correct answer. But guys, remember, 35 is closer to 36 and 36 is for 4 liters. 30 is closer to 32. So this would become the answer to 3 liters, right? And that according to me is the correct answer for this question. Nasal cannula, oxygen being delivered 3 liter per minute. That's the FiO2, right? So FiO2 is 30%. Okay, so that's nasal cannula. Next question. Identify the mask in the image being used. This was at the time of COVID also. It's been asked after that as well. What is the mask being used for the patients of COVID-19 patients? Is it Venturi mask, Hudson mask, nebulizer, or non-rebreathing mask? Yes, anyone? क्या है correct answer? Simple question. Is it Venturi? No. Is it Hudson mask? No. Dr. KK says D. Correct. Non-rebreathing mask is the correct answer. So now, when you are discussing these various types of masks, remember, oxygen delivery devices, guys, can be classified into 2 types when we speak of the classification, right? So if you talk of the oxygen delivery devices, they can be classified into 2 types. One are the low flow devices and other are the high flow devices. So the low flow devices would basically be your nasal cannula, which we just saw, or the nasal prongs. Then you have the simple face mask. Then you have a partial rebreathing mask. And then you have a non-rebreathing mask. Right. So maximum FiO2, a nasal prongs works between 1 to 6 liters and the maximum is 44%. Simple face masks works between 5 to 10 liters, the maximum is 60%. Okay. So maximum if you will see is 60. Partial rebreathing, it works between 10 to 12 liters, the maximum is 70%. Non-rebreathing works between 12 to 15 liters, the maximum is 90%. Out of all the low flow devices, the maximum FiO2 is given by the non-rebreathing mask. Right? Non-rebreathing mask. Right. All of you have given me the correct answer, guys. All of you who marked it correctly. Right? So, now, a lot of people, you have marked it correctly over here. Many of the times people say, sir, why not Venturi mask? Venturi mask normally, right, is a part of your high flow. High flow has 2 devices that we are talking about. High flow has the high flow nasal cannula and you have the Venturi mask. Remember, high flow nasal cannula can give 100% maximum FiO2. High flow. Venturi mask, but the maximum FiO2 is only 60%. Though it is a high flow device. So what's the difference between them? In the low flow device and the high flow device, the point is the high flow devices normally are the ones which give you a fixed output. You know how much is going to the patient actually by how much you've started. It does not depend on the patient's respiratory rate or respiratory rate. All of them, the low flow devices, they normally depend on the patient's respiration, on patient's tidal volume. Okay, it depends on the patient's tidal volume. All of them, all the low flow devices you will see, all of them, they depend on the patient's respiratory volume, patient status, patient's ventilation. But high flow, it is going to deliver irrespective of that. They are fixed output devices. In fact, Venturi mask is based on Bernoulli's law, air entrainment, Venturi principle. Okay, it gives 60%. So if you have to identify in the exam, this is what is called nasal cannula. You people already know it, right? This is a simple face mask which can also be called as a Hudson mask. This is what is called as a non-rebreathing mask. A non-breathing mask normally has a valve over here. There is the presence of this valve, and this valve makes it a non-rebreathing mask. Along with the valve, there is always a reservoir. This whole mask is called non-rebreathing. This is the reservoir. The presence of the reservoir is that oxygen gets collected over here, and it can provide almost 90% FiO2. Clear, everyone? So these are oxygen delivery devices. This is a very important topic. Last 2-3 years, one question from here has always been asked. NEET PG, INI, CT, FMG, all of them. Okay. So let's go to the next question. This is what is called as the Venturi mask. If you will see, it's written 60, 35, 31, 28, 40. Based on colors, this is what is telling you the fixed output, how much it is going to the patient. Similarly, what you see over here, this is what is called your high flow nasal cannula, HFNC. This is your Venturi mask. Both of them are called high flow devices. They are the ones which give fixed output. Okay, this has a humidifier. You can identify it by the presence of a humidifier. Okay. Next question. During resuscitation, a patient is kept in the right lateral recovery position as depicted in the image. Which of the following does this indicate? Unconscious patient, pulse and breathing present. Unconscious patient, pulse and breathing absent. Unconscious patient, pulse present, breathing absent. Unconscious patient, pulse absent and breathing present. Anyone? What would be the answer? Yes, what do you think so? One answer. Dr. NTA director says, sir, आपका नाम क्या है? My name is Dr. Vinish Srivastav. Okay. NTA director. Okay, बाकी लोग आंसर दो. Okay, I've got just one answer till now. Yes, anyone? What is present, what is absent? So confusion is between C, A and D. नहीं यार, इतना confusion तो नहीं होना चाहिए. What you see in front of you, मैंने पहले बोला, this is recovery position. Recovery position. ठीक है? Recovery position दिख रहा है. Unconscious patient तो सब में दिया है. लेकिन अगर pulse और let's put them one by one. Pulse or breathing absent है, तो will you let the patient be like this? No, it's not possible. So option B is out. None of you have marked it. Correct. The problem has been between C and D. Pulse present and breathing absent. अगर breathing absent है, you can't leave the patient like this. You will have to give breath. If breathing present and pulse absent, you will have to do something for the pulse, right? But the point here is that pulse and breathing both are present. Hence, you have kept the patient in recovery position. That's the answer. The correct answer is A, correctly pointed out by Dr. Anand Raj. Okay? अरे किसी नाम पूछा था, मेरा नाम डॉक्टर विनीश है यार. VINISH. टेलीग्राम आईडी भी वही है. एनी क्वेश्चन और डाउट यू कैन आस्क मी माय टेलीग्राम आईडी. DRVINISH. That's my telegram ID. Any questions or doubts, you can direct me directly. ठीक है? Going forward and discussing this question, I'll discuss 3 of them, and then I'll discuss the whole part of CPR. In the last, as these are the previous year's topics ना, तो और 2 question discuss करेंगे, और उसके साथ फिर we'll discuss the CPR part of it. Okay. So which is the maneuver being performed in the image? Again, last year's question. What is this being done? Is it head, tail, chin lift? Is it jaw thrust, head extension, or inline manual stabilization? What is being done? Yes, Dr. KK has given one answer. और लोग? Dr. KK, correct, absolutely correct. This is what is seen as head, tilt, chin lift. So 2 question हो गए. This is, ये तो फिर भी ठीक है. एक एग्जाम में लिखा था, ठीक है, हेड टिल्ट चिन लिफ्ट, एक था जॉ थ्रस्ट, इनलाइन स्टेबलाइजेशन, और एक जगह एक ऑप्शन दिया था नेक बेंड. दिस इज एक्चुअली एग्जाम क्वेश्चन एंड स्पाइन ट्विस्ट. इमेजिन नेक बेंड, स्पाइन ट्विस्ट, ये ऑप्शन दिया था एग्जाम में. इट हैज बीन गिवन इन एग्जाम बाय द वे. but thankfully not this option was not given in the previous exam. Head tilt chin lift is the answer. The last one before we discuss, again a recent question, which of the following, this was INI-CT question, which of the following is incorrect about quality CPR? Rate of compression 100 to 120 per minute, respiratory rate 20 to 25 per minute, depth of chest compression 5 to 6, or allow adequate chest recoil. Yes guys, इसका correct answer क्या है? What is incorrect about the quality CPR? So the correct answer here is, yes, is it A? No, A is not the answer. 100 to 120 correct hai. Depth of chest compression 5 to 6 is also correct. Allow the chest recoil, ye bhi correct hai. It is B. When you are giving breaths to a patient, guys, right, the number of breaths that you are giving, right, high quality CPR is about 10 to 12 per minute. That is the part of ALS, advanced life support. So we are discussing BLS and ALS, right? Basic life support. Remember, the first thing in basic life support is the scene safety. This is the first step. The first step is scene safety. Scene safety agar hai to sabse important hai, that's the first point. The next step is check for response. If the patient responds, leave the patient. If there is no response, then the next step comes call for help. You know, this is very important. Call for help, so that you can ask the people to come and they can get their automated external defibrillator, they can get emergency equipment, they can get supraglottic devices, they can get laryngoscope, they can get endotracheal tube. So that is why call for help. So till now we have not checked pulse and breath. Till now what has happened? Just scene safety, you check response, call for help. The next step is when you check for breath and you check for pulse. That is the next step after that. So when you are checking for breath, what do? The breath is checked by looking at the visible chest rise. How do you check for pulse? So the pulse is basically checked at the carotid. You can check the carotid, you can check the brachial, you can also check the femoral, right? Brachial in pediatric patients, adults में brachial normally check होता है. So basically the pulse that you will check is carotid. You can check femoral also in adults, but pediatric patient you go for brachial. So you check for the pulse. Remember, the time point is 10 seconds. Both are supposed to be checked simultaneously within a span of 10 seconds. Don't give more time than 10 seconds to check for breath and pulse. If both breath and pulse are present, means breath is there and pulse is there, keep the patient in the recovery position, the question which was asked. Okay? Okay, pulse and breath both are present. Pulse and breath both are present. Pulse bhi hai, breath bhi hai. Keep the patient in the recovery position. Agar patient ko pulse, now the next point is, if the patient has pulse present, matlab pulse feel ho raha hai carotid, and you can't feel the breath. Breath nahi ho raha hai. There's no breath. So therefore what is missing is the breath. So what will you do in this scenario? So in the first scenario, what we did was, when both pulse and breath are present, we kept the patient in a recovery position. When pulse present and breath absent, you need to give breaths to the patient. Can you see how many breaths you're supposed to give? This was the question asked in the next one. 10 breaths per minute. One breath is every 6 seconds, or 10 to 12 breaths per minute is what you're supposed to give. Right? Keep on checking pulse every 2 minutes, and हो सकता है थोड़ी देर pulse खत्म हो जाए. Then you have to start the CPR or keep on checking the pulse. This is the place where you can give naloxone if you think there is opioid overdose, which means pulse present and breath absent. The third, which is the scenario when someone has actually collapsed many times, is that the pulse, the breath is also absent and the pulse is also absent. Here you will start the CPR, right? Here you start your CPR. What are you supposed to start in the CPR? When you do a CPR, guys, you are supposed to do cycles of 30:2. Your CPR has to be basically cycles of 30:2. But how do you do those cycles? So basically you're doing a chest compression, you need to take care of the airway, and you're taking care of the breath. CAB, chest compression, is the lower 1/3 of the sternum. The rate is 100 to 120 per minute. The depth is 2 to 2.4 inches or 5 to 6 centimeter. And remember, allow for the chest recoil so that whatever chest compression you're giving, it comes back again. Airway, remove the obstruction. If there is a vomitus, if there is a foreign body, take it out. अगर वो foreign body नहीं है, then most of the times it's a tongue falling back. In that case, what will you do? You don't have any instrument with you. You can't intubate. You are alone. So here you do is what is called the next step: head tilt, chin lift. Head tilt, chin lift. What does it do? It takes the tongue away from posterior pharyngeal wall, so that now when you give breath to the patient, the breath will go. Hence, airway comes before breathing. Right? That's the reason why airway comes before breathing. So head tilt, chin lift. Acha, if you think the patient is fractured cervical spine, you can't do head tilt and chin lift. So what do? There you prefer to do jaw thrust. That is why jaw thrust becomes important. Fracture cervical spine, go ahead for jaw thrust. Right? So that is how you take care of the airway. Then when you give breath to the patient, remember, always give 2 breaths at one time. Inspiration, give over 1 second. Expiration over 1 second. Of course, you need to look at the chest rise, whether your breath has gone correctly or not. Okay? So inspiration 1 second, expiration 1 second. Look at the chest rise. And no excessive ventilation. Okay? How do you give a breath? Breath can be given mouth to mouth. It can be given mouth to mask. It can be given mouth to nose. It can be given bag mask or ambu. If you're on the road, it's very difficult to find ambu or bag mask, anything. You have to give mouth to mouth breathing. That's why mouth to mouth becomes important, right? So bag mask ventilation with oxygen, with reservoir ideally is the best thing. What are we supposed to do? We are supposed to do cycles. The same thing that I said. We are supposed to do these cycles of 30:2. 30:2. You're supposed to do them for 2 minutes. After 2 minutes, check for the pulse. If there are 2 people, rotate the compressor. Okay. After 2 minutes, when you finished off cycles of 30:2, right? Normally 5 cycles of 30:2, and then after 2 minutes, you rotate the compressor so that the one who is doing chest compression will do the breathing. The one who was giving a breath will do a chest compression, right? So this 30:2 stays everywhere as 30:2 except in a pediatric patient with 2 rescuers where it becomes 15:2. And of course, in a neonate, it becomes 3:1, right? Yeah. Then, till now, AED was not there. But in case you get AED, remember, सबसे important, immediately attach AED. Whenever you get it, exam में question आया हुआ है. Immediately attach AED. Whenever you get AED, to check the rhythm, right? Immediately attach it. Immediately. So you can attach it one below the right side below the clavicle, and left side is mid axillary. So you can make it right and left. Right below the clavicle, left is mid axillary. You can also do anterior posterior nowadays. AP आगे पीछे भी correct करते हैं. Even that is allowed, anterior and posterior. And then you check for the rhythm. If the rhythm is a shockable rhythm, means you can give shock. That case, give a shock. Do not do a pulse check. Start your CPR for 2 minutes. And after those 2 minutes, have gone, as we were discussing here, after 2 minutes, rotate the compressor, check for the pulse. If it is not felt, then what you do? You go back. Again, what to do? Look at the rhythm. If the rhythm is shockable, next step is give a shock. After shock, start CPR. After CPR, keep on continuing this cycle till the time you get advanced life support people. Victim starts to move, or 30 to 40 minutes. ठीक है? But if the rhythm is non-shockable, then in that case, do not give a shock. Just start your CPR and continue that for 30 to 40 minutes, or till the time ALS people come or victim starts to move. Point is, once you get defibrillator, you are supposed to attach defibrillator immediately and check for it every 2 minutes. Every 2 minutes you need to check the rhythm, right? Every 2 minutes of that CPR that you've done, every 2 minutes of CPR, you need to check the rhythm. Okay? Thumbs up, guys. Is this clear? Every 2 minutes. Clear है सबको? Now, the point is, what are the rhythms which normally you get? What are the dying rhythms of the heart? Okay? So when you check for the rhythm, and in case you have a ECG machine, right, what are the dying rhythms of the heart? You get a pulseless ventricular tachycardia, which can be like this, or you can get a ventricular fibrillation, which is like this. You can get pulseless electrical activity or asystole. So according to the rhythm, pulseless ventricular tachycardia and ventricular fibrillation, these are the rhythms where you give a shock. Monophasic defibrillator give 360 joules of shock. Biphasic defibrillator give 120 to 200 joules of shock. On the other hand, if you get pulseless electrical activity or asystole, remember there is no shock. But now you've got a rhythm, means you've got people to help you out. This becomes ALS now. Advanced life support. When you see of ALS support, it means now A, B, C, D are there. Means you can put an endotracheal tube, there is a laryngeal mask airway, and hence you can give a breath 8 to 10 per minute, which can be given continuously. The chest compression and the breathing are irrespective, no 30:2 now. Once you have endotracheal tube, remember no 30:2. Here you need to take an IV or an intraosseous access, right? And drugs which can be used are basically adrenaline, adrenaline, amiodarone, lignocaine, magnesium. In between, keep on thinking about the reversible diagnosis. The reversible diagnosis is your 5H and 5T. That's the reversible diagnosis, 5H and 5T. Keep on thinking anything is there or not. Also, you can monitor the CPR by diastolic blood pressure waves and by EtCO2 and tidal carbon dioxide. That's important for CPR as well. Okay, so this is your CPR. Now, any questions or doubts, guys? We've discussed everything in CPR also. ठीक है, कोई डाउट है किसी को? तो should I go forward? Almost done. ठीक है, I'll take about 10-15 minutes more and then we are done with the complete session. It's almost a complete revision of anesthesia, sort of, from all the questions that we had, right? Next question, from the image given below, the marked circle denotes cannulated screw for compound tibial fracture, intraosseous cannula for fluid therapy, K wire for tibial fracture, bone marrow aspiration. This was again an image based question. I think this was NEET PG only. What's the answer, guys? B, correct. This is what is called intraosseous cannula for fluid therapy. Absolutely correct. When you put an intraosseous cannula, what are the places you can insert? See, normally this is used in pediatric patients, because in emergency for a pediatric patient it is difficult to find the vein. So you can use the intraosseous line, but it can also be used for adults. The commonest site that you can use is the tibia. People also use the femur. There can be humerus. Okay, you can use the sternum and the anterior superior iliac spine. So all are these places where you can go ahead. Dr. Anand Raj also says B. Dr. Surya also says B. Correct. Correct answer वही था, intraosseous cannula. ठीक है, intraosseous cannula for fluid therapy, used for pediatrics as well as adults, right? So next question, which of the following test is depicted in the following image? Yes. Now this question is easy because I am talking in anesthesia, but if it comes in the exam, guys, it becomes difficult. This question is easy when I am discussing as a part of anesthesia. Yes, what's the answer? Correct. Correctly mentioned. This is what is called Allen's test. Allen's test is used to check the patency of the collateral supply, right? In case you are inserting a radial arterial line, it is checking the supply of the other side. So for us it is important because we insert a radial arterial line, it gets filled up within less than 7 seconds. This establishes that the collaterals are patent. What is the use of a radial line then? This is the invasive blood pressure measurement. It measures the blood pressure, beat to beat blood pressure. It tells you the beat, with every beat, how much is the blood pressure. Important for critically ill patients in the ICU, transplant patients, cardiac patients who are there in the ICU. So in ICU, in OT, major surgeries which fluid shift is where we use it. Radial arterial line. The places where you put an arterial line can be the radial artery, it can be the ulnar artery, it can be the femoral artery, it can be the brachial artery, it can be dorsalis pedis artery. Arterial line. Similarly, there can be central line also, guys. Central line, remember, is inserted in a vein. Arterial line was in an artery. Remember, the most common is internal jugular vein. Then there is subclavian. You can use femoral vein. So these are all veins. Basilic and cephalic. Right? When you put internal jugular and subclavian, see, complications can be there from all of them. You can have an arterial puncture. All of them can lead to arrhythmias because the tip of the central line lies at the junction of superior vena cava and right atrium. So all of them can cause arrhythmia, all of them. But internal jugular and subclavian have a peculiar thing because they're in the neck. They can cause pneumothorax, and on the left side they can cause chylothorax. Again, important point, right? Chylothorax can also be there. So femoral, maybe you're not going to get this thing, but at least in IJV and subclavian, pneumothorax and chylothorax can be there. Okay, this has been asked in the exam. Central line, there can be bleeding, infections, right? And use, it's a direct access. It measures the CVP. Alright, that's the use of central line. You can give vasoactive drugs, total parenteral nutrition, chemotherapy, TPN, blood collection, all that. In fact, arterial line, you can all, apart from blood pressure, you can also, ABG sample can be collected from there. ABG sampling, right? Arterial line. So this was the central line. Remember, IV cannula are important. IV cannula. So remember, they can be 20, 22, 24 and 26. And here you can have 18, 16 and 14. So remember, the most common that we use is 20, which is pink color. Then you get blue in color, which is 22. It is a smaller one. So pink is used in adults. Blue is used in adult, can be used in pediatric. Then 24 is yellow in color. This is used in pediatric, it can be used in infants. 26 is what is purple in color. This is used in neonates and preterm neonates, which means from 24 to 26, these are thin gauge. On the other hand, 14 to 16, they become thick gauge, right? And these 18 one is green in color, 16 is gray in color, and 14 is orange in color, right? And they are used for fluid and blood resuscitation. Alright, blood and fluid resuscitation. Flow rates. This is around 50. Alright. The other ones will become almost double of that. This will become 90, this becomes 180, this becomes 280, 270. Sorry, 170 and 280. On the other hand, you will find that the 24, this is around 15, this is around 20, this is around 33. This is the flow rate in ml per minute. Okay. This is the flow rate in ml per minute, approximate. This is the flow rate of the IV cannula. Fine, so we discussed this also. Next question. I'll take about 10 minutes more. 3 or 4 more questions are there, rest we are done. All of you, I think some of you have been there right for the 2.5 hours here. चुपचाप बैठो बेचारा, सुन रहे हो तुम लोग. थक तो नहीं गए? Tired? 2-3 more questions and then we are done. This is a FMGE question, January. Which of the following is not an indication to use BiPAP? Obstructive sleep apnea, unconscious patient, high PCO2 and low PO2. Yes. Don't think FMG questions are easy. Huh? A lot of people, FMG is very easy. No, FMG questions also tend to be difficult. They are. Anyone, what's the correct answer to this patient? To this question? Anyone? So, which of the following is not an indication to use BiPAP? Obstructive sleep apnea, unconscious patient, high PCO2 or low PO2? Okay, someone has given an answer. Anyone else? Okay, we are talking of BiPAP, bi-level positive airway pressure. Okay, the correct answer here is unconscious patient. Remember, it's not obstructive sleep apnea, guys. In fact, CPAP and BiPAP are the treatment for obstructive sleep apnea. Okay, for a high PCO2 and low PO2, again you can use BiPAP, right? It is unconscious patient. So if the patient is unconscious, if the patient is sedated, you can't use. What is BiPAP? See, BiPAP is a mask like this. So this tube here, एक second, let me take the white. This tube here gets attached to a machine, and this machine is then going to give a amount of pressure, and this pressure is kept at the nose of the patient, right? So what does this do? This high pressure which is going inside the patient's nose through the mask which has been attached. Can you see how tight the head strap looks over here? The head strap is totally tight so that there is no escape of oxygen coming out from here, right? So oxygen is there, you have increased the pressure. It's called PEEP valve also, right? Same thing, it's the pressure valve which is there. So now what is there is this high pressure, it prevents the alveoli from collapsing. Normally what happens is during inspiration, the air goes inside, oxygen goes inside, and then there is the bloodstream. So oxygen will go over here and carbon dioxide will come over here, right? During expiration, the alveoli become like this. So what does this do? This is what is called as continuous positive airway pressure or bi-level positive airway pressure. That positive pressure, it prevents the alveoli from collapsing, so that during the expiration also the alveoli is open for longer duration of time, because of which more gas exchange can take place. So CO2 comes out or PO2 goes inside. So therefore BiPAP, CPAP is used for what? If there is someone's PO2 is decreasing, giving or using this CPAP or BiPAP, what does it do? This maintains a positive pressure. Because of the positive pressure, the alveoli are open for a longer duration of time. Because they are open for longer duration of time, so what happens? More gas exchange takes place. Because of more gas exchange that is taking place, your PO2 of the patient improves, and in case there is PCO2, means PO2 increase, oxygen is going inside and CO2 is coming outside, so CO2 will decrease. So therefore for high PCO2, remember the PCO2 is going to decrease because more gas exchange is taking place. So BiPAP is used as a treatment for high PCO2, low PO2 and obstructive sleep apnea also, right? But here what you need is the patient should be breathing on his or her own. Here the patient is normally awake. The patient is not unconscious, okay? There is no loss of consciousness. If there is unconscious, you know, the patient is breathing on his or her own. That is about CPAP, BiPAP, breathing on own, right? Spontaneous breath is there. I am not giving a breath to the patient. That is BiPAP and CPAP. So the patient needs to be awake. If he becomes unconscious, you can't be using BiPAP. You have to intubate and put a ventilator. Thumbs up everyone. Sir, please tell about FiO2, PEEP, CPAP and BiPAP. I know, I knew you people will have that doubt. Let's take it in the form of question. Right now, hopefully you've understood CPAP. In fact, guys, what is PEEP? PEEP is nothing but CPAP. Now, what I will discuss with you right now, see, when you ventilate someone, guys, ventilation can be of two sorts. Ventilation in a patient, let's go to oxygen delivery devices. Wait, oxygen delivery. So these are your oxygen delivery devices. A patient in the ICU is not improving with either of them. Not in the ICU, a casualty. Patient is not improving with any of these devices. You put the patient on high flow nasal cannula. Like a COVID patient, not improving here, you put on high flow nasal cannula. Patient is not improving with high flow nasal cannula. What is the next step? You might intubate the patient, right? The next step can be, let's intubate the patient. But the point is, before you intubate the patient, there is one more thing that you can do, right? Before you intubate the patient, there is one more thing that you can do, and that is use non-invasive ventilation. So this ventilation that we speak about can be of two types. Ventilation can be non-invasive and invasive. Non-invasive ventilation is when you put when you're using a face mask for the patient. Invasive, when you have endotracheal tube or you have a tracheostomy. When you give a breath when you're going from high flow nasal cannula to a further sort of a ventilation through a face mask, what you can do is a CPAP, continuous positive airway pressure and bi-level positive airway pressure. Okay, this is what is PEEP. It's the same thing, PEEP, which is attached to a ventilator. Right? Invasive ventilation means you have put endotracheal tube and tracheostomy, and from that you put a patient on ventilator. Now a ventilator has various modes, guys, various modes. I mean, we don't have that much time to discuss all of them, but some things we'll discuss, not the modes. The modes can be control mode, support mode, volume control, pressure control, SIMV, pressure support. For every ventilator mode that you get, you can attach PEEP. What is PEEP? PEEP is called positive end expiratory pressure. So what is PEEP? Positive end expiratory pressure, right? Which means at the end of expiration you are keeping positive pressure, which is nothing but is CPAP. It's the same thing. You are preventing the alveoli from collapsing. The only difference is that CPAP is given in a patient through face mask who is awake and who is conscious, and PEEP is attached to a ventilator mode. Normally this patient will be on endotracheal tube, so the patient may be unconscious, or the patient is sedated, or the patient is paralyzed. That's the difference, otherwise both are same. CPAP and PEEP are the same thing. Then how CO2 leave out of the apparatus? Which apparatus? Dr. Babu says. पहले ये तो क्लियर हो गया, unconscious, positive end pressure, positive end expiratory pressure. So unconscious patient, ठीक है, sedated and paralyzed patient. Where there is endotracheal tube, you are putting PEEP. So PEEP is given through the endotracheal tube, and it keeps the expiration for longer duration of time, and air exchange takes place. Right? So Dr. Babu says, how does CO2? There's a valve, na? यहाँ पे एक valve होता है. There is a. अच्छा, you are asking here only in BiPAP. In BiPAP, there's always a valve from where there's CO2. When the patient, remember this works on the patient breathing on his or her own. So you get a high pressure which is being delivered from here. That is inspiration. When the patient breathes out through the valve, it moves out as well. Just like a breathing circuit, guys. Just like a breathing circuit, it has those valves. Hopefully that point is clear, Dr. Babu. Otherwise, we go to the next question. Right? Here is that FiO2 question that you were asking. Acute pancreatitis patient intubated on ventilator with the following settings. Tidal volume 420, respiratory rate 32, PEEP is 12, FiO2 is 0.9. On the ABG, pH is 7.33, PCO2 is 48, PO2 is 110, bicarb 28, saturation 100. What is the next step in management? Is it decrease FiO2, decrease respiratory rate, increase tidal volume, or increase the PEEP to 14? This has been asked in the exam. Let me know what is the answer. It's a difficult one. Remember, these questions regarding ventilators are not easy. Ventilators are difficult. Okay. So this is an acute pancreatitis patient. He's intubated on ventilator, which is okay. The tidal volume is 420. Respiratory rate is 32. PEEP is 12. Right? FiO2 is 0.9, which means 90%. Okay. On that you find pH 7.33, PCO2 is 48, PO2 is 110, bicarb is 28, and saturation is 100. That is the ABG. Right? First look at the ABG of the patient. pH I am getting 7.33. PO2 is 110. PCO2 is 48. Bicarb is 28. And saturation is 100. Right? This is your ABG. Right? Dr. Surya says the answer. Absolutely correct. You have to decrease the FiO2. Absolutely correct. That's the answer. Absolutely correct. In this ABG, what is the abnormality you are finding? The patient that you find over here. Right? What is the point here? Tidal volume is 420. This is low tidal volume normally. So if it's an ARDS patient, a low tidal volume with high PEEP is correct. a low tidal volume with high PEEP is correct. Okay, there's no problem here. This can be done. Low tidal volume with high PEEP. Right? Now, that's correct over here. FiO2 is 90%. Now the point is, if your ABG is maintaining the PO2 and the saturation 100, do you need to give 90% oxygen to the patient? Because remember, this was what can cause oxygen toxicity. The whole concept is try to reduce oxygen as early as you can. Now, decreasing the respiratory rate, let's look at the options. If you decrease the respiratory rate from 32 to maybe 20, it's going to increase the PCO2. So you're not going to decrease the respiratory rate, out of question. You increase the tidal volume. If you increase the tidal volume, it is going to increase ventilation. Remember, decreasing the respiratory rate is going to increase the carbon dioxide. If you increase the tidal volume, it is going to increase tidal volume. Increase tidal volume will increase ventilation, and this will again decrease carbon dioxide. Matlab, these two things are playing with carbon dioxide of the patient. Decrease of the respiratory rate and change in tidal volume are playing with the PCO2. Right? These two things are playing with the PCO2 of the patient, these two parameters. If you increase the PEEP to 14 from 12, you increase it to 14, again the PO2 will increase. So this will increase the PO2, and saturation is anyways 100, it cannot increase further. So the only thing that you can do over here is to decrease the FiO2. If you decrease the FiO2 of this patient, your PO2 will come down slightly, and saturation around 90-95 is acceptable. You don't want 100% with PO2 of 100, 110. So the correct answer is option A, to decrease FiO2. Is that point clear? And now, normally when these questions come, guys, basically, so most of the things is that someone's PO2 is less. So if the PO2 is less, how will you increase the PO2? Increase the FiO2. More oxygen will go in. Right? That is one way to do it. Increase the PEEP. It will be open for longer duration of time. More gas exchange can take place. In I's to E ratio, you can increase the inspiratory time. That's one more thing that you can do. Right? If the PO2 is less. If the PO2 is more, which you can see, in that case, decrease the FiO2. If you want, you can decrease the PEEP also, depending if the thing is needed or not. Second thing, you can find if the PCO2 is less or if the PCO2 is more. If the PCO2 is more, right, you need to increase the tidal volume, increase the respiratory rate, or increase the expiratory time. So more ventilation will take place, more carbon dioxide will move out. If the PCO2 is less, you will decrease the tidal volume and decrease the respiratory rate so that the PCO2 can be increased. Mostly this is the point which they ask you in the exam, right? This is the one. हाँ डॉक्टर बाबू FiO2 वही होता है, fraction of inspired oxygen delivered. FiO2 is inspired oxygen, fraction of the inspired oxygen being delivered to the patient. Okay, so the correct answer here is option A, decrease the FiO2. FiO2 is fraction of the inspired oxygen being delivered to the patient. Is the fraction of the inspired oxygen. ठीक है? Is it clear everyone? Hopefully. Right? This was a difficult one, I totally agree. Not an easy one. Alright, 33-year-old female undergoing history. This was again last year's NEET PG question. 33-year-old female undergoing hysteroscopy polypectomy under general anesthesia. During the procedure, the fluid deficit was 2000 ml. Which of the following could be the biggest risk for a patient in this condition? DIC, acute tubular necrosis, pulmonary edema, or thromboembolism? Yes. Hello guys, Dr. Burhanuddin has said hi. I hope I am pronouncing Burhanuddin correct. Hi guys, hi. थक गए यार हम भी. It's been almost 2 hours 40 minutes. Huh? Dr. Babu has given one answer, D. Once you've done, then we'll start with the guitar again. इसको साइड में हटा रहा था. Anyone? Apart from Dr. Babu who has given the answer D. So guys, remember, this is hysteroscopy. Hysteroscopy polypectomy means they are going to insert, female patient is there, gynec patient, right? This is a gynecological procedure. This is a gynac procedure going on. Hysteroscopy means they are going to evaluate through the hysteroscope that is passed inside. They want to evaluate, the uterus. So hysteroscopy is done there like this. So they are going to pass the hysteroscope, right? They are passing the hysteroscope inside and they're going to evaluate the polyp or whatever is there. And through this, they will try to take, if there's a polyp over here, they'll cut the polyp also. So polypectomy is being done, hysteroscope. Here what you need to do is, it's like, TURP. All of you must have heard transurethral resection of prostate. Almost the same thing, where fluid is going from here inside and it's kind of dilating the uterine cavity. And here, they are trying to see if there's a polyp. They'll try to, dissect over there, or cut it over there and take the polyp out. Now, here lot of fluid is used. Just like in TURP, the same thing can happen in hysteroscopy. Right? All the same things can happen. So in this patient, because of positioning, there can be complications. In this patient, there can be, with anesthesia medicines. Now, when you're entering the endometrial cavity in the uterus, there can be cervical trauma, false passage, uterine perforation, all that can take place. Intraoperative bleeding, right? There can also be embolism because, because of the pressure, the channels of the blood vessels may be open from here. So you will have the blood vessels open. So there are chances of embolism also. So embolism can be there. But more importantly is, if you don't monitor how much fluid is going, it is going to create a fluid overload in the patient. That is pulmonary edema. Okay? Yes, normal saline is preferred, but people use glycine also. So normal saline as well as glycine is used. But this is what is to be used, normal saline. Okay? That absorption of the fluid will take place. As I said, the same, the blood vessels are open from here, from where there can be an embolus going inside. Just like how an embolism can take place, because if there are blood channels over here and you can have a small embolus going in, which can be embolism. Similarly, in the blood channel, a lot of fluid absorption takes place. And this fluid absorption can lead to pulmonary edema. So therefore, guys, the answer to this question is pulmonary edema, option C. Okay, the correct answer is option C, pulmonary edema. Okay, guys. Okay, so this was the question and I think we've covered a lot of them. Thank you. So you've joined me right from the beginning. Some people have been there right from the beginning till now, sitting quietly, listening to me. Thank you so much. My Telegram ID is Dr. Vinish, Vinish. That's my Telegram ID. And my Insta ID is Dr.Vinish. Any question or doubt you can ask me. Right now, if there are any questions, please you can go ahead. This is my Telegram ID. So any question I can try to answer to the best of my knowledge. And this is my Insta ID, Dr.Vinish. So you can follow me there as well. Dr. Babu says great session. Thank you. अब एंड करते करते एक गिटार का गाना हो जाए. I know normally I would have students singing along with me, but here I can't listen to all of you. Had it been a Zoom session, I would have loved it. But let's start with some song. If there are any questions, you can go ahead. I'm still waiting. Dr. Cupcake says, sir, all the questions of previous years question discussed. Yes, mostly last 2 years I've discussed. 3 years I've discussed everything. Almost last 3 years. Okay, 2 to 3 years. You'll have to see. I have also included questions from INI-CET. I have included questions from FMGE, which were absolutely recent ones, and NEET PG as well. The almost questions that we've discussed today are 25 to 28. I don't remember, but they are between 25 to 28 questions that we've discussed in this 2.5 hour session. And they include questions from INI-CET also. They include from FMGE also, the recent ones, as well as the NEET PG, which was held last year. Okay. कोई सॉन्ग किया जाए. थोड़ा सा सेशन लाइट हो जाएगा, नहीं तो इट वाज सच अ हेवी सेशन, 2.5 hours. ओके, सो एक सॉन्ग करते हैं और उसके बाद फिर आई विल कैच अप विथ यू द नेक्स्ट टाइम व्हेन वी प्लान अ सेशन नाउ. ओके, जो स्टार्ट से गाना की तो उसी के साथ कर लेते हैं कंटिन्यू. डॉक्टर बाबू से सर कैन यू टेक अ सेशन ऑन लेरेंजियल मास्क प्रोसील सुपीरियर नहीं होगा, सुप्रीम होगा. एलएमए सुप्रीम, प्रोसील एंड एलएमए सुप्रीम. यस डॉक्टर बाबू, वी कैन प्लान दैट. That's what I said, we'll plan another session later on. Abhi ke liye this was the previous year's topics as what students has asked for. Some students had said, you know, the way that we get our messages, we get our feedback. So students had said that let's have a session where we can have previous year's questions and more directed towards the previous year topics. So the focus of this session, more than the questions, was the previous year topics. I feel that is more important, and all the people who are teaching, they feel it's not about the same questions getting repeated, it's about the same topics that you need to be aware of. So it's for PYTs mostly that we have done. Okay, Dr. Babu? तो जो स्टार्ट किए थे वही गाने से एंड करते हैं जो हम लोग ने शुरू किया था. गुलाबी आंखें जो मेरी की शराबी ये दिल हो गया, सुबह को मुझको तो मेरे यारों समझना मुश्किल हो गया. ओ मेरे दिल के चैन, ओ मेरे दिल के चैन, चैन आए तो दुआ कीजिए, मेरे सपनों की रानी कब आएगी तू, आई रुत मस्तानी कब आएगी तू, बीती जाए जिंदगानी कब आएगी तू, चलिया तू चलिया. मेरी नीट का सीट कब आएगा तू. ओके, नीट पीजी का सीट कब आएगा तू. Alright, so there it guys, that's it. Thank you for joining me at this session, and Dr. Babu will think about this session. Please put your feedback that way, right? We'll plan a session accordingly, and we'll see that more questions and things we can discuss. Dr. 𝐂𝐄𝐝 says, amazing sir, subject and mood dono sorted. Correct. Thank you so much, Thomas. Thank you so much. That's the reason we teach here, or everyone who's teaching, that's the reason, you know, so that you people can understand something and it helps you for your exam, right? So get your seats, and hopefully people get good marks, good options, the things that you're looking out for, and let us know, and all the best to all of you. Do well. ठीक है? Dr. Babu says, चिल्लिया ये कौन सा गाना है? जितना मेरे को याद होता है उतने में गा सकता हूँ यार, जितना मुझे याद है, राइट? चलो इतना था ना, एक और गाना कर लेते हैं. लेट्स डू वन मोर सॉन्ग बिफोर आई फिनिश ऑफ द सेशन. वन मोर सॉन्ग लेट्स डू. ठीक है? आई नो हिंदी सॉन्ग्स ओनली यार, एंड आई नो माई जनरेशन, नॉट माई जनरेशन, बट यस ओल्ड सॉन्ग्स, नॉट द यंग वंस, जो तुम लोग को पता है वो सब नहीं. एक और कर लेते हैं. Thank you. Thank you everyone for joining me. Thank you for listening to the whole session. Thank you for listening to these songs also. I know I'm not a very great singer, but yes, try to play it a little bit so that we get de-stressed, right? All of you, do keep something to de-stress yourself, and all the best for the exams. Do well. So, right? I'll keep now. Take care. All the best.